Hello guys, how are you doing today?
Good, doctor. Thank you. How are you?
I'm fine, thank you for asking. So let's wait for the new volunteer and then we will start in a while.
Okay.
Okay. So let's start our topic, the most high yield and the okay, the gastroenterology, pathophysiology and pathology. So so I'd like to invite a volunteer to go through the STEM and then we will discuss it, okay? So, any volunteer?
I don't think we can see your screen. Or is it just me?
Wait a minute. Sorry, I
Screen is
didn't.
not visible.
Okay. Now you can see my screen.
Now we can see. Thank you.
Okay, welcome. I
Okay, I
forgot.
can go.
Yeah, doctor, go ahead.
Yeah, so which of the following is the most likely cause of this patient's condition? So a 46-year-old man is brought to the emergency department by paramedics after an episode of
Mm,
large volume hematemesis. He was
mm,
going over some papers at work when he suddenly fell nauseated and started vomiting up bright red blood. Physical examination reveals a palpable spleen.
mm.
Endoscopy shows bleeding esophageal varices. A liver biopsy performed 2 days later shows
Yeah,
no abnormalities. So, which
yeah,
of the following is the most likely cause of this patient's condition?
yeah. So basically, let's discuss in detail what's happening going on this patient. So basically, the patient is having a very large volume of episode of large volume of hematemesis. Okay, and then after that, he come with a bright red blood vomitus, physical emotional palpable spleen, and endoscopy reveal show bleeding through esophageal varices. A liver biopsy is performed, no abnormalities. Never la. Basically, the most important point here is you found a bright red blood in vomiting. The topmost differential diagnosis will be you or the problem, either it will be esophagus. Number one, topmost differential. Okay. And secondly, stomach. But the top more differential will be your esophagus. If you vomit a bright red blood and that stay no longer in the stomach and goes out as a bright red blood, not a clotted blood. Okay. So another, this is one of the most important point. Now, basically the spleen is also enlarged and having a bleeding of varices. So what's the cause of bleeding varices here? Basically, I have discussed the normal the supply of the stomach, duodenum, and every part of these. Okay, but let me give a brief overview that you can understand what's going on over here. Basically, there is a varices over here. This causes the blood to vomit as heavy blood. Okay, and also there is enlargement of spleen as well. So it's mean that there is any abnormality in these veins, also in these veins. Are you with me, guys?
Yes, doctor.
Now,
Yes.
now let us go to this venous drainage. That why this spleen is enlarged and why this esophageal varices is taken place. And here is your liver, right? So basically, your here's your superior mesenteric vein going all through this pathway. Okay, above the fore part of the duodenum and behind the first part of the duodenum. Okay, also there is a vein that drain from a spleen, and here it combined with the superior mesenteric vein, and the name changes a portal vein. So this is your portal vein over here, right? Portal vein, hepatic portal, right? Another is another vein that also contribute to this tributary. This is your superior mesenteric vein. This is your inferior mesenteric vein. This is your splenic vein. And one important thing that supply the esophageal is your here your tributaries that came and drain over here in the portal vein. There are the short gastric and this your left gastric. This is your left gastric vein. This is your right gastric vein and drain into the portal hepatic vein. Okay. So now this is a portal hepatic vein. Okay. So from the liver, here is also a vein. This is your hepatic vein. Hepatic vein that drains into the systemic circulation, right?
As you say, yeah.
Yeah, systemic circulation as IVC. Perfect. Now, if the problem is going on over here and here, the first point. So it means that there is any problem in the left gastric. Okay. Also, there is a problem in the spleen as well. The spleen is also enlarged. So also the problem in the splenic vein. Number second, first, second. So it means the problem is either going on in portal hepatic vein or either in hepatic vein. Portal hepatic vein. Now, either the problem is here, either the problem is here. Right? Have you got the point? Now, how will we differentiate between the hepatic vein and portal vein? We will see the liver biopsy. And it show the liver biopsy performed 2 days later show no abnormalities. So it means the liver parenchyma is fine. What does it mean? Either a problem is here, one problem, or either a problem is here. What do you think? Where the liver parenchyma is in normal stage. So what do you think? Where the problem?
The portal
Portal
vein.
vein.
Perfect. There is a abnormality over here. So you have diagnosed that this is a portal vein, and here is any thrombus that lead to these visual varices, and that also lead to the splenic
बन गया सो इधर से बात हुई
enlargement. Okay, so portal vein thrombosis. Okay, now what do you think? Acetaminophen toxicity, long-term alcohol consumption, but Chiari syndrome, constrictive pericarditis, and portal vein hypertension. So basically, if a patient is if sorry doctor, if a patient is using chronic high yield point, if patient is having a liver insufficiency, mean the liver is compromised, either hepatitis B C virus, either viral infection, autoimmune. The toxicity of acetaminophen will be a 4 milligram according to new guideline. Now, if the liver is normal, okay, so the toxicity dose will be a double 8 milligram. Just remember this thing, important thing. Now, is the patient is using any acetaminophen drug in the history in this stamp?
No,
no
No.
Any using of the long-term alcohol consumption?
no,
No.
no
Perfect. What is the Budd-Chiari syndrome? When the thrombosis in the hepatic vein over here, when the problem is over here, right? So that thrombosis will lead to damage to this parenchyma as well. Okay, and that will lead to esophageal varices, splenomegaly. Okay, all will be the problem. But in this case, the liver parenchyma show no abnormality. So can we exclude this part?
yes
Okay. Now, what about the constrictor pericarditis?
we have no history of fever or friction rub or anything like that so
Yeah, perfect, perfect. So, have you cleared your point that it is confirmed case of portal venous thrombosis?
sir I joined late can you just briefly explain what you told
What's your good name?
sir Dr. Mahanur
Okay, Dr. Manur. Okay. So basically, we are discussing a patient came to your department of emergency department having a large volume of hematemesis.
yes sir
Okay, and hematemesis that lead to a bright red blood.
yes sir
Okay, now and having a palpable skin. The first most important thing to know the cause of bright red blood. Whenever a bright red blood came to your vomitus, the first differential you should have this blood is not waiting in stomach. When you wait, it will
and
be
I guess
yeah. The most differential of the first differential will be your esophagus. The problem is going in esophagus. Now, having a palpable spleen, a spleen is enlarged. It means enlarged, and having esophageal varices. It means that the problem is over here in esophagus as well as in spleen. Okay, now the liver biopsy is performed and have no abnormalities. So let's discuss. I will discuss the venous drainage. Whenever you clear the venous drainage of this part, then you will know the pathology of the. Now, a spleen and having a superior mesenteric artery over here. Okay, it is combined with inferior mesenteric vein over here, superior mesenteric vein, splenic vein, and that two tributaries combine with the superior mesenteric vein and form a portal vein.
yeah
Okay, so the portal. This is your left gastric that supply the esophagus distal part and the stomach, and this is your right gastric that supply the lesser curvature of stomach. Okay, that also drain into your portal vein. The portal vein then goes into the liver, and then when out of the liver having a hepatic vein that drain into inferior vena cava. Okay, now now if the problem is in your esophagus and spleen, either the problem will be in your portal vein or either the problem will be in your hepatic vein. Okay, how will exclude both of these? You have to look the liver biopsy. A liver biopsy is fine. If the liver biopsy is fine, so liver parenchyma is a normal.
Yes, so we can exclude the first three options: no alcohol, no acetaminophen.
Yeah. So acetaminophen toxicity, no in the stem. Long-term alcohol, not in the stem, and but carry excluded on the liver biopsy here in the stem. And constructive pericarditis, no inflammation, no friction lobe. It is forward leaning, relieving factor. So it is not mentioned in this case. Okay.
Yes, yes.
So we got the point.
Yes, sir. Thank you
And
so much.
okay, acetomin toxicity is that if liver is insufficiency. If liver is having hepatitis and autoimmune, every problem going on in the liver. So the toxicity dose will be 4 milligram. If a liver is normal, the toxic dose will be 8 milligram. Okay, so I think you have got the answer.
Yes, sir. Portal vein thrombosis.
Okay, that perfect. So basically, you
Excuse me,
have
sir. Can you please repeat this dosage like 4 and 8? What's the difference between both of them?
the both of them difference is that if the
This
patient is
acetaminophen,
yeah,
yeah, the
with
dose you're telling.
4 milligram and 8 milligram. These are the toxicity dose. 4
Sir, is it
milligram.
milligram or
For
gram?
gram, for gram, no milligram is gram.
Sorry,
Is it
Gram,
milligram or gram, sir?
it is gram or milligram.
Because
gram.
Grams. It's grams,
because
actually.
Okay,
normally we take like 250 milligram or
okay,
500
okay,
We
milligram
give
of
okay,
six,
dose.
okay,
650 mg for 4 times at least.
okay. So it is 4 gram and 8 gram, right? So in 4 gram will be in your liver insufficiency. Whenever the liver is compromised, like in hepatitis, any condition that inflame the problem and the lung. Actually, autoimmune hepatitis, anything that will your toxic dose be of 4 gram. Okay, and for the normal liver, if the patient is having a normal liver, the toxic dose will be 8 gram. Okay, that was the point. Now,
Okay, thank you.
okay, so basically, for the question you have read, that was your a little bit revision of your venous tributes, that you should know the renal tributes and know a little bit of confusion between the Budd-Chiari and portal vein thrombosis. Okay, if there is a problem in the liver, so that will lead to the Budd-Chiari syndrome. If the liver is normal, then go with the portal hypertension. Okay, now any volunteer here?
Can I read?
Yeah, okay, go ahead, doctor.
Which of the following part of history is most likely to reveal the cause of this patient's current condition? A
Mhm.
69-year-old man, a 69-year-old man is evaluated for abdominal pain. Upper gastrointestinal endoscopy show a single shallow 1 centimeter ulcer in the duodenal bulb and mild gastric erythema. Biopsy specimen from the gastric antrum do not show Helicobacter pylori.
Mm-hmm.
I cannot see your screen.
Yeah,
The screen is not visible, so
not visible. Why?
I don't know. I cannot see.
Wait a minute, wait a minute. Is it right now? Is it visible now?
Yeah, yeah. Now
Okay,
I
good.
can see. The biopsy specimen from the gastric antrum do not show Helicobacter pylori, and stool testing for H. pylori antigen is negative. Which of the following part of the history is most likely to reveal the cause of this patient's current condition?
Okay. A patient is having abdominal pain.
1 centimeter.
Okay.
Duodenal.
Upper OGD is performed in a single ulcer in a duodenal bulb and mild gastric erythema. A specimen is for a biopsy specimen from a gastric content do not show H. pylori. and two is negative for positive. Now, let's discuss it. What is the most likely cause of this current condition? Let's know about the what's the problem that is going on over here: esophagus, stomach. Okay, basically, there is a mass in the question stem. There is a mass that are contributing over here like that. Like this, a patient having a 1 centimeter ulcer in the duodenal bulb. So it means the problem is having in the duodenum, right? The problem in a duodenum. And 1 centimeter ulcer over here. Okay? And there is a H. Now, the most important thing to remember is that the H. pylori overgrowth is present will be your an antrum.
Yes.
Okay?
Yes.
The H. pylori growth mostly in your antrum. Okay? Now, these are asking about the patient is having a so whenever there's a duodenal ulcer and other ulcer that is present in your gastric, so this is a gastric ulcer. Okay, and this is a duodenal ulcer. So the duodenal ulcer is also called a peptic ulcer disease. Ulcer disease. So how will we differentiate between the gastric ulcer and the duodenal ulcer? Okay, the first point is on the basis of history. Whenever you eat food after a meal, in the gastric ulcer, the pain starts. Due to if there's ulcer present over here, so the parietal cell will release HCl. That HCl will irritate this ulcer. So there will be a pain. Okay. And what will be in the peptic ulcer? Whenever after a meal food came over here. Okay. So that so there is a bicarbonate present over here. We discussed the physiology before that. There is a secretin I cell D cell secrete the bicarbonate, so there will be a relief of pain after eating. Okay. Now let's come to the another point that is now. Okay. So the most common cause of we will discuss the gastric ulcer later. Now the most common cause of peptic ulcer disease is number one. Number one. 95% cases there is H. pylori. Okay, that causes the duodenal ulcer. And the most important thing, whenever you find an ulcer in any part other than duodenum, the duodenal ulcer will be non-malignant. Other proven wise by duodenal ulcer are 95% benign, and esophageal ulcer, gastric ulcer, any duodenum, any ulcer other than duodenum is almost malignant, proven by biopsy. Okay. Now, the first cause is H. pylori. The second most common cause is the use of NSAID.
NSAID?
Yeah, perfect. Whenever you hear the name peptic ulcer, the most important thing to remember the H. pylori and guess and NSAID. So, in this condition, the patient is having a 1 centimeter ulcer in the duodenum bulb, like here, ulcer is present over here. Okay, so it means there is a duodenal ulcer. Okay, so the most common cause will be either a pylorus, number one, and it will be NSAID. So, biopsy specimen, I told you the gastric anthem do not show pylori. Whenever you take the specimen to look for the H. pylori, you have to take the specimen from the antrum part, where the growth of the H. pylori take place. Are you with me, guys? So it shows negative H. pylori, and it's also a stool negative turn. It's also negative for H. pylori. So which of the following part of his history is most likely to reveal the patient current condition? So
Medication.
what do we think over here? I have discussed you H. pylori and NSAID.
It's just medication use.
Medication.
Perfect. So how it's medication? You have got the point. But how this NSAID causes the duodenal ulcer? Basically, whenever you take NSAIDs, it basically inhibit your COX inhibition. It's basically inhibit a COX enzyme, cyclooxygenase. Okay, so COX are further divided. It decreases your thromboxane 2. Okay, and that inhibits the platelet aggregation. Okay, secondly, it inhibit the COX also stimulate the production of prostaglandin and prostaglandin E2 and prostaglandin I2. It's help in the production of increased acidity. Okay, it control the acidity. Whenever you take the COX inhibition like NSAID, it will decrease the prostaglandin E2, so there will be increased production of acid that will damage the walls of this mucosa. Okay, so that mucosa will lead change into your gastric mucosal injury. So that mucosal injury will lead to ulcer. Okay, so the ulcer is from the prostaglandin E2, and if there is a bleeding present over here, so that will be due to the thromboxane E2 deficiency. And it will be low due to the your NSAID COX inhibition. Okay, so basically, in this question, you have to know the two most high important high yield concept that duodenal ulcer have. Number one, the 95% is having H. pylori infection, and the 95% cases the duodenal ulcer are benign, and rest other three are almost malignant, otherwise proven by biopsy. Okay, and the second most common cause of the duodenal ulcer is
And
NSAID. Okay, have you got the point?
yes, sir.
Okay, so basically you have to think over the stem, the what they're asking. If they are asking about the journal, so you have to go to a journal, and if it's asking about the detail, then you can go into details. Okay, any volunteer from the next question?
May I?
Yeah, okay, go ahead.
Which of the following is most likely cause of the patient's dysphagia? A 46
Mhm.
old woman comes to the office due to dysphagia. The patient had difficulty swallowing both liquids and solid as well as frequent episodes of regurgitation and cough while eating. She also had weakness in her extremity and a rash. The patient has no prior medical problems and take no medication. Vitals are normal. Physical examination show erythematous eruption on the upper eyelids. The oropharynx is clear and oh, so your screen.
Sorry, the screen is timing. I think it has been changed to the yeah.
It's
Wait a minute. Wait a minute, doctor. The timing has changed to this now. Go ahead.
okay.
Sorry.
Cardiopulmonary and abdominal examination are remarkable. She has difficulty lifting her arm above her head and standing from a sitting position. Which of the following is most likely cause of this patient's dysphagia?
What do you think?
Some muscle
Um,
weakness going on along with dysphagia.
And having a rash as well, and her extremities. Any volunteer that can help patient is having
Dermatitis?
perfect erythematous eruption of upper eyelids. The oropharynx cardiopulmonary examination is unremarkable. It means the problem is not in your oropharynx or in oral cavity. The problem is not your cardiopulmonary session examination. Abdominal examination is also excluded. So the problem of your dysphagia is not due to your gastrointestinal cause. So you have to exclude the gastrointestinal cause. She has a difficulty in lifting her arms above her head. So there is a problem in the proximal muscle as well.
Mm.
And it also help and standing from a sitting position. The muscle in is proximal muscle weakness. Which of the following molarly causes this dysphagia? Okay, now discuss having a discussion. So let remove the DD came over the exclusion basis. Now, atrophy and fibrous replacement of a distal esophageal muscularis propria. For example, this is your esophagus, right? And the esophagus mucosa muscularis, submucosa muscularis adventitia. The muscularis layer is replaced by your fibrous tissue. It means the esophagus is not working properly because the muscularis layers has been atrophy and fibrous. Okay, so what will be your cause over here? Fibrous replacement and atrophy. It is due to
Systemic
per-
sclerosis.
perfect. It is due to your systemic sclerosis. How? Systemic sclerosis is your disease that will lead to the fibrosis of the muscularis layer. Okay, and how will we differentiate it from the above statement? So, what's going on over here? Basically, the if the patient is having a scleroderma, the clinical feature will be your there will be also a reflex disease as well if it is not working properly. Okay, so there will be the esophageal gastric juncture also relax, so there will be a reflex of acid, so that will lead to cough. Okay, that will lead to aspiration. Okay, that acid can damage this esophagus, and that can lead to esophagitis, inflammation of esophagus due to reflux of acid. Okay, now if there is this is your cardio this is your gastrointestinal problem, esophagitis of the systemic sclerosis. What are the extra gastrointestinal manifestation in systemic sclerosis? You will be having a problem in your ulcer. Present will be your in your digital ulcer. There will be a calcinosis, and the most typical rash will be the here there the present of rash that her extremities. Okay, so rash will be not that time. Okay, and it also not disturb the your striated muscle. And the most important thing in the scleroderma, it affects your lower esophagus muscle over here, right? Now, second point, diffuse esophageal predominant inflammation of esophageal mucosa. I got the point. Eosinophils. What does it mean? What does it indicate?
Eosinophilic esophagitis.
Perfect. If you see any eosinophil mast cell IgE, it means it's having a hypersensitivity going on.
Yeah.
Yeah. So What will be the cause of this esophagitis? That's eosinophilic esophagitis over here. So the eosinophilic esophagitis will typically present with you having a epigastric pain, okay, and also it will lead to the esophagitis. But in esophagic esophagitis is inflammation of esophageal only. It's not the systemic cause. Like you don't have be a proximal muscle weakness, you
Mm.
don't having a muscular rash or other extremities, and the rash will be not there. Okay. Now, inflammation and degeneration of esophageal mesenteric plexus. What do you think over here? Inflammation and degeneration of mesenteric plexus. If there is a degeneration of your mesenteric plexus and the lower esophagus, so how it will look like? Can anyone tell me? Wait a minute, I will just make a diagram. It will be present like this. So what do you think? If the lower esophagus mesenteric plexus has been damaged, so what do you think? How it is looking like? There is no relaxation of this muscle. So what do you think?
Echolalia?
Perfect. Having a lower inflammation degeneration of esophageal mesenteric plexus means there will be achalasia present in the lower esophagus. So how will we differentiate it from the above statement that in achalasia the typical presentation will be you
Just
will be
solids and liquids only, maybe.
yeah, you will be having a liquid and folic dysphagia, and then you will be having a regurgitation as well. Also there will be heartburn present over here because food came over here, okay, but the acid are present in too much quantity in stomach, okay. So this acid is not neutralizes because the food cannot come over here, so there will be heartburn as well. And it is also the problem only related to the esophagus. There will be no proximal muscle weakness, there will be no rash. I got the point, and there will be no problem in your in your difficulty, no problem in your oropharyngeal muscle. Okay, now outpouching of hypopharyngeal mucosa through a weakened muscle. What do we think?
That's the diverticulum.
Yeah, perfect. It's your diverticulum.
Diverticulum.
Yeah, yeah, perfect. It's your diverticulum over here. It is a zinc diverticulum. So whenever a patient presented to you with a zinc diverticulum, the most important thing will be you are having the the food came over here and it will lodge over here. So that food will sometime be okay. So that will lead to hal-
Halitosis.
perfect halitosis. Tosis. You will be having a dysphagia. Okay, also you will be having a regurgitation from whenever you contract, you will have regurg and also aspiration into your trachea. But it is also not associated with your proximal muscle weakness. It is not presented with this rash. Have you got the point? Now, if the patient perifascicular atrophy of muscle fiber in the proximal esophageal muscular propria, what do you think?
That's the scleroderma esophageal involvement.
Sorry?
So this is actually scleroderma, right? That's involving the esophagus.
No, 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 no. Scleroderma is basically a systemic sclerosis, and it is you are the first point over here. Okay,
Okay.
it is basically you are a sclerosis. Whenever you heard a sclerosis fibrosis, it
Okay.
means you are having a displacement of the muscularis layer, and that is typically going to your systemic sclerosis, and your then another name is scleroderma. So
Okay.
yeah, so in scleroderma, the distal esophageal will be the proximal will be spared, and the problem will be on distal esophageal. But it is present not with the muscle weakness and like that. Okay, have you got the point? Now, basically, it will be having a dysphagia. I explained it earlier as having a dysphagia, having a esophagitis, also having aspiration. But the systemic cause will be not. It will be having a ulcer calcinosis that will be not with the ongoing step. So perivesicular atrophy of muscle fiber in the proximal esophageal muscular propria. What do you think? What is it? It is a myopathy of the muscle fiber. So what's can anyone tell me what is it? Pathophysiology of this. What this is called?
So this is dermatomyositis because there is
Perfect.
dermal manifestation plus muscle manifestation.
Yeah. So how will you differentiate between dermatomyositis from a myositis?
There
Skin,
is
I think.
no, yeah.
The cotton.
Perfect. Perfect. So it is basically a perivesicular trophy muscle fiber and proximal esophageal muscular. It is dermatomyositis. Okay, and myositis, you will be only having inflammation of your muscle, not the skin. So how will you remember it? If it is derm, it will lead to skin problem and muscle as well. Okay, and myositis is only related no skin. It's related to only a muscle. And which part of muscle? If it will be your epimysium, in dermatomyositis, the muscle layer that is near to your skin, that will be affected. And in myositis, the layer of muscle fiber that is away from the skin will be affected. Have you got the point? Now, the main concept is that to remember how will you differentiate on the a cause of this. If your patient is having an atrophy and fibrous tissue going on, that will be your systemic sclerosis. If the patient have a diffuse esophageal eosinophilic inflammation, esophagitis, inflammation and degeneration of mesenteric plexus, achalasia, outpouching, zinc diverticulum, passive perivesicular atrophy of muscle will lead to your dermatomyositis. It is basically a topic of your MSK, but just remember the following things like how will you exclude the following? Have you got the point?
Yes, doctor.
Okay, so basically the answer of the previous question is your A.
Perivesicular atrophy.
Yeah, basically dermatomyositis. Now, can anyone go with this step and that he can you volunteer?
A 3-month-old boy is evaluated for dizziness, abdominal distension.
Hmm?
A contrast, do you hear me?
Okay, it's performed and shown in the image below. Okay, so
Okay.
and
So
we do. Mhm.
which of the following is the most likely cause of this patient's condition?
So what do we think? What do we, let me discuss. Let's see this picture. Oh wow! Basically, your this is your colon. Okay, a large colon, a very big colon over here, and it is your rectum. A rectum is a normal size. It is contracted. So have you see the big colon, mega colon over here? Hmm?
Yes, megaphone.
Yeah. So what's your cause of the megacolon? And what is the pathophysiology of megacolon? Can anybody have read this megacolon? What's the disease called?
Hirschsprung's disease.
Heart.
Hirschsprung's disease.
Yeah, Hirschsprung disease. So what's your pathophysiology? Number one, you have to remember it is Hirschsprung disease.
Cells.
Sprung disease. Secondly, what's the pathophysiology of it?
It's actually the aganglionic cells present there. Ganglion are absent.
So you mean ganglion are absent over here, right? So that okay. So
Yes.
that is the agglomerates that is unable to relax or contract. I got the point.
Yes.
So this is your pathophysiology. And how will we treat this cause? How will you treat this?
We'll
Can
dissect the section of colon.
perfect, perfect, perfect. So basically, this is your normal part of stomach, and this is your ileum part, and this is the normal part. Okay, we will dissect here and here. We will remove this part. We will remove this part over here. Okay, then we'll stitch this esophagus over here. Stitch over here. Stitch over here. Okay, so that will lead one stitch. So there will remove a glandonic point. Okay, so how will you diagnose the hush spring? Diagnosis is through important point.
Suction biopsy.
Biopsy, section biopsy, and it's basically a suction biopsy. Have you got the point? This is a hush spring case, and it's a typical case of hush spring disease. Okay, just remember this picture. It is a very high yield picture and it will come across your question. And hush spring disease is a very important and that came every time in the step 1 exam, and you have to remember this x-ray. Okay, so basically, which of the following is most likely the cause of this patient? So what do you think? I think we have gone through your embryology. Let me discuss a little embryology. Let me test your knowledge that you have remembered your embryology or not.
Excuse me, sir.
Yeah, yeah, go ahead.
Yeah, I have a question. So, as you said, the diagnosis is by suction biopsy. So, usually we do this like the resection biopsy or the tissue taken biopsy. So, why we doing the suction biopsy? What's the importance here? Like, what's
Basically,
the difference between, like, you mean that by sigmoidoscopy or colonoscopy, they're going to suck the tissue from that place or just to dissect the tissue? I couldn't get this biopsy. Can you
yeah,
please explain?
basically this resection
I,
and suction, yeah.
I think, doctor, because here the Maintarik and the Urbach, they are not in one place. They are embedded between two. So that's why we need to take the whole thing to make sure that we saw that both these plexus are absent for the diagnosis. That's what I think. I'm not sure.
You got the point. Basically,
Like I
in
mean, suction is something like you can aspirate something, like you can collect like the fluid or something to aspirate or suction. But sometimes like resection is to take a piece of tissue that containing their mucosa, submucosa or muscularis. So we are not taking actually the actual dissection of tissue from that place. We are just taking the secretions. You mean like that suction biopsy, or just to suck the tissue inside the I don't get it.
basically you- it's I think you have your question are all right that you have taken the section biopsy from this side, but don't confuse yourself. Just for your knowledge, that if you want to know the difference between a section biopsy and your resection biopsy, right? Basically, it's not the high yield point in the step 1 exam, but for your remembrance, in section biopsy, you have to remove the mucosa and submucosa. Okay?
Okay, now got it. Thank you. Yeah,
And
because this word suction is like first time in this question come. Usually they say biopsy, biopsy. So
yeah,
therefore
yeah, yeah.
I
So
got it
don't
open.
yeah, so basically don't confuse yourself in the biopsy. Just go to the question that it will not take time. Basically, section biopsy and the type of biopsies that are present in your step 2 course, right? I will
Oh,
explain it. It will take time so that you will be then the rest of the question will be left. Okay?
okay, thank
You
you.
got the
Yeah,
point.
sometimes like there is biopsy, but sometimes in some option there is suction biopsy. So sometimes we can miss this small point. So either it's biopsy or there is suction biopsy. So I did this mistake, therefore I am clarifying it. Yeah, thank
Basically,
you.
is basically the section biopsy is less invasive and relatively safer, and we will take it from the rectum and the colon. In most of the cases, it is typically in it is because mucosa and submucosa suction, and in the
Okay.
resection we take the full thickness of the it is a surgical excision.
Okay. Thank
It
you,
is a
sir.
full,
Thank you for your time. Thank you.
yeah, it is a full thickness graph. Okay. Okay, now let's discuss your knowledge about embryology. Okay, is there a disruption of the recanalization? What do you think? I have discussed, told you.
That's the
Did
atresia,
it
Sorry?
duodenal atresia.
Perfect. Atresia. Perfect. Incomplete rotation of intestine.
Malrotation.
So what will be your the causes? What will be your the problem that malnutrition is correct?
It can lead to
Gastrochiasis and amphela.
hypocalcemia.
Yeah, basically you will be having a malnutrition. So in the malnutrition cases, you will be having the volvulus. And have you got the point?
band? Blood band also.
Yeah, bad bang. And what about the lack and intestinal compression by superior mesenteric artery? What did it lead to?
Superior mesenteric
This,
artery syndrome.
So
this
what will
SMA
lead to?
syndrome. SMA syndrome.
Pressure on the third part of the duodenum.
Perfect. So there will be obstruction, right?
Yeah.
Perfect. So lack of mesenteric ganglionic cells. What do you think?
Hirschsprung disease.
Perfect. It's a megacolon. Have you got the point?
Yes.
I think you have remembered the embryology well.
Yes, sir. You taught us well.
Yes,
Uh,
yeah.
Thank you very much. So basically, this is having a lack of the mesenteric plexus, and that lead to the cause that is the Hirschsprung disease. Okay. Just remember the high yield point in embryology and anatomy. So that you know everything, right? So if you know any canalization problem, go with that region. And if new students want to learn the embryology, go to your our video of the embryology of the day one or a day second. Go to the video, you will learn the high yield points and how to solve a question on the embryology in that video. Okay. Now, any volunteer, go with this statement.
I
I
can
can
do
do
it,
it,
sir.
doctor.
Yeah, new volunteer can go ahead.
It's okay, Dale. You can.
Okay.
Okay, thank you. This patient's condition is most likely caused by which of the following processes?
Mm-hmm.
A 55-year-old man comes to the office due to intermittent abdominal pain. He has no difficulty or pain with swallowing. The
Mm-hmm.
patient occasionally uses over the counter pain medicine for osteoarthritis of the right knee. He does not use alcohol or tobacco and
Mm-hmm.
has no a history of cancer in the family. He works as an air traffic controller at the busy airport. Upper GI endoscopy shows an ulcer in the distal duodenum.
Mm-hmm.
Fasting serum gastrin concentration is at the upper limit of normal and
Mm-hmm.
rises in response to IV secretion. This patient's condition is sorry, I made a mistake. Rises in response to intravenous secretin. This
Secreting.
patient,
Yeah,
yeah,
that.
this patient's condition is most likely caused by which of the following processes?
Okay. The patient condition is most likely cause of the which processes. Okay. A patient is doing NSAIDs for the pain control for osteoarthritis for knee. Okay.
Yes.
It does not use alcohol and tobacco. Has no history of cancer from and traffic controller had to be upper. Yeah. So the present of this duodenal ulcer in the part of the duodenum, right? So what do you think is going on over here?
That's a duodenal ulcer.
Perfect. Now, the most important thing came over here. Fasting serum gastrin concentration is at a upper limit of a normal. Now discuss. Now remember what
Doctor,
is
but the ulcer is distal,
Growth.
right? Not the proximal duodenum.
this person is the distal duodenum, right? Sorry. Basically, the ulcer is present in your distal duodenum here or either here. Okay, not in the proximal. Here you are. Okay. Now discuss. I have told the physiology. What is this cell and what is this cell?
Parietal cells and chief cells and then G cells, B
Mhm.
cells.
Yeah, I think you remember all the cells over here, right? So let me
Yes,
tell which cell secrete gastrin.
the third one in the stomach, the one in the antrum.
What's your is what is good
G
name?
G
cells.
cells. G cells.
Iman.
No, what's the good name of this gastrin releasing
Ah,
cell?
I thought my name G cell.
Okay, okay, no problem. And
G cells, yeah.
oh, perfect, perfect. And
Yeah.
what's which cell secreted secreting?
S
The S
cells.
cells.
S cells.
Perfect. So this is the S cell. The G cell secretes gastrin that causes the parietal cell to release HCl, right?
Yes.
Is it right?
Yes, sir.
Now, whenever this secretin is released by the
S
S
cell.
cell, right? So this S cell have a negative, it's released bicarbonate, right? Have you clear the concept of the bicarbonate, bile secretion, and it also decreases the acidic secretion that if acid came over here and a food are present over here, so it have a negative impact on this parietal cell that no more acid is required over here, right? So food are present in the duodenum, so no need of acid to be in stomach. Okay, so the are you with me, guys?
Yeah.
Now
Yes, doctor.
basically the fasting serum gastrin level is our upper limit, and a fasting mean the patient is at fasting, there is a no food in stomach, right?
Yeah.
But the gastrin level are in upper limit, it mean increase. Okay, I've got the point. Gastrin
Yes.
level is upper limit and no food are present. What does it indicate? The gastrin is stimulating, the gastrin are high whenever the no food present over here, but the gastrin is secreting more and more and more and more, and that secreted the HCl. HCl causes this, HCl came over here and causes duodenal ulcer in the duodenum. You got the point?
Yeah, so that means there's some growth that's producing excessive gastrin.
Yeah. There's a problem in the gastrin that causes the gastrin to release more. Okay, so rise in the response to intravenous indicate. What does it indicate?
Gastronoma.
Gastronoma.
Perfect. Basically, the fasting gastrin should be at low level because no food mean no need of HCl. No need of HCl mean low gastrin. So low gastrin mean the G cell are not activated. Okay, so at the fasting level, the gastrin level are at upper limit. So it means the gastrin is secreting excessively, not controlling. So what does it mean? Having a tumor over here. Have you got the point? So what is it called? One name, Ashwin told it is a gastrinoma, right?
Yes.
Gastrinomas. Also, it is called gastrin releasing secreting tumor. Okay.
Yeah.
What's the another name of it?
Zollinger Ellison.
Perfect. The Zullinger Ellison syndrome. Okay. Now, what happened? So, what do you think of the cause of this condition? Like, if you
Neoplasm.
yeah, basically the correct option is no. What's the
Neoplasm.
Helicobacter pylori? The basically the
If
most it's
disease, then it can cause H. pylori, right?
sorry.
Sir, if it decreases, so then we have to go for the H. pylori infection.
Okay, okay. That's perfect. So it's decreasing in H. pylori infection. Perfect. If there is a
Also,
mucosa,
in the
sorry.
proximal duodenum, not in the distal. Also, the ulcer will be in the proximal, first part of the duodenum, in the helicobacter, not in the
Yeah,
distal mostly.
yeah. Perfect. You are taking it right one. Now, mucosal immune dysregulation. What do you think? There is a problem in your epithelial, and that will lead to dysregulation of this mucosa layer. So, mean that mucosa layer has been disrupted. Okay. So basically, it is having a laceration, and it is basically you are a Crohn disease. We will discuss the Crohn disease and a further question, but just remember it is having a immune dysregulation of the mucosa cell. The mucosa shall all shut away. So basically, Crohn disease having a dysregulation of mucosa immune response. Okay, so what's happening in a stress? What does stress mean? Can anyone elaborate it? So I think, wait a minute. Okay, wait a minute. B and E are of a same pathophysiology, right? Are
Yeah.
you with me, guys? Helicobacter pylori and NSAIDs are not of that cause. It will be the proximal duodenum, okay, and it will be in your control of gastrin. Okay. Now, what's the stress? The stress typically mean a broad term used for the any trauma, any problem and shock, bleeding, and any severe stress. Like it will cause you are if you're having a very trauma, heavy bleeding, shock, okay, and burns most important. Okay, so basically, if the patient is having disruption of a mucosal anywhere, but a patient is present in this condition, and a patient is presented to the emergency department as having a shock, either hypovolemic septic, obstructive any shock. So there will decreased blood supply to the gastrointestinal. So there will be a decreased blood supply to the mucosal. So mucosal will represent having a ulcer. It's also present. It is a most highly important point. It if also it is present in burn. So burn having a hypovolemic shock, so that will lead to the ulcer in the gastrointestinal, low blood supply to the gastrointestinal. Okay, so we have included the stress, no any history of stress, no trauma, no burns, no shock, no heavy bleeding, right? NSAID we excluded, H. pylori excluded, neoplasma and autoimmune gastritis, autoimmune destruction. If there's having an autoimmune destruction or a chronic gastritis, so there will be a no. Basically, gastritis is involving the body and fundus. So there will be a no parietal cell and no. What's this cell? Chief cell.
Fifth cells, yeah.
Perfect.
Yeah,
Chief
chiefs.
cell, no chief cell, no parietal cell. So there will be a no HCl, no intrinsic factor, and no pepsinogen. No HCl, no intrinsic factor. No intrinsic factor mean low vitamin B12. Low vitamin B12 mean megaloblastic anemia. Megaloblastic anemia mean corpuscular volume will be greater than will be 100. HCl mean there will be no breakdown of anything. There will be a accumulation of bacteria, everything. Okay, and low HCl mean no conversion of pepsinogen into pepsine. Also, there is no chief cell, so that will also lead to low pepsinogen, and also decrease a chloridria is present into autoimmune gastritis. Okay, basically it affects the fundus and body, not the antrum part. Have got the point? And have you got this MCQs?
Yes, doctor.
Okay. So basically, the patient is having a gastrinoma that secreted secreting the gastrin and high level. That gastrin simulated the parietal cell. The parietal cell secretes the acids. So acid damages the duodenal part. So having a gastric ulcer. Okay, sorry, a duodenum ulcer is present in the distal part. No, basically, this will lead to the formation of this question also having the problem in the main stem is to having a fasting gastrin level is most important thing. Okay, and the to know the difference between the distal duodenum ulcer and proximal duodenum ulcer. Having a proximal duodenal ulcer, your suspicion should be the peptic ulcer disease. Okay, now go ahead, and that's the neoplasm. So any volunteer can go through the question.
I can
The
read,
patient.
doctor.
Oh, sorry, go ahead.
It's
Yeah,
okay,
yeah.
Sarah. Fine.
Okay. The
Till.
patient most likely has a tumor secreting which of the following molecules? A
Mhm,
46-year-old woman comes to the office with persistent diarrhea, weight loss, and abdominal pain. Her
mhm,
diarrhea started several months ago.
mhm,
She has no fever, melena, and metathesia. The patient has not traveled outside of the country and has not drunk from any untreated freshwater sources.
mhm,
She has had no recent hospitalization or antibiotic use. Her
mhm,
sister has a history of celiac disease. Upper
mhm,
endoscopy reveals post-bulbar duodenal and jejunal ulcers. The
mhm.
patient has most likely tumor. Which of the following molecules?
Which of the following molecule? I think I have. I think you have the concept of this question. Which of the following? Have you got the concept or not? Basically, the answer is present in the distal, not in the proximal part. So the most of the distal is having a tumor that will lead to.
The gastrinoma.
This ulcer. Yeah.
Yeah,
During
perfect.
the
Perfect. I think you have got the concept from the previous question that is having a gastrinoma over here. Have you got the point or not?
Yes.
Okay. So it is basically the patient is having a problem having going on that will lead to basically the tumor also it is also causing a weight loss. So you have think the tumor, but it is the question is not to diagnose which tumor it is, but to diagnose
Substance.
which substance is releasing. The question is you have to diagnose first it is a Zollinger-Ellison syndrome, then Zollinger-Ellison syndrome causes gastrinomas, that gastrinoma release a gastrin. Okay?
Yeah.
Yeah. So gastrinomas, duodenal ulcer, peptic ulcer, not that confusing, but you have to remember that where the ulcer is present. If it is present in your proximal part, so what will be your causes?
That will be
It's
the
fine.
duodenal.
Right? NSAID. Yeah.
Okay, NSAID and H. pylori. If it is present into a distal duodenal or a jejunal ulcer, so most probably it is due to
Neoplasms.
neoplasm. Yeah, so almost Zillinger-Ellison syndrome. So I think we have read the question. Give me 2 minutes so that I came and put the charger thing. Can anybody see my screen now? Yes, doctor. Go ahead with the new MCQs.
I can go.
Anybody? Yeah, doctor, go ahead.
Depletion of these cells from the gastric antrum is most likely to cause which of the following conditions? Researchers studying GI pathophysiology analyzed hundreds of gastric mucosal biopsy specimens taken from patients who underwent endoscopy at a local tertiary care center. They
Mhm.
noticed that colonization of gastric antrum with S-shaped gram-negative bacteria is associated with a decreased number of somatostatin producing antral cells.
Mhm.
Depletion of these cells from the gastric antrum is most likely to cause which of the following conditions?
What do you think? Let me discuss a little bit. I think you have what because this question. Basically, oh yeah, right. So basically, the patient is having basically in the research they are talking about the somatostatin, right? Which cell
Yes.
secrete somatostatin? Can anyone? Can anyone tell me which substance, which cell secrete somatostatin? I have
D
S
cells.
cell.
D cells.
which
D
cell?
cells. D
D.
cells.
D
D.
cells.
Okay, D cell. It is a D cell. I think the fourth one is D cell. Number one is parietal cell. Number second is chief cell. Number third is
G cells.
G,
G cell. And number fourth is D
D.
cell.
D.
So what's the function of this D cell? The D cell secretes somatostatin. What does somatostatin do? What do you think, guys? What's the function of this somatostatin I have told you yesterday?
It's
So
I
like
still.
an enzyme.
it decreases
Party
all the.
police. It stop all the to stop all the enzymes.
Mm.
So yeah, it's like a party police that stop everything.
It inhibits everything.
Yeah,
Yeah,
it has
It is
inhibitory effect.
it inhibit
inhibits
it.
the
Oh, okay, inhibit the parietal cell, right? Okay, in it inhibits the G cell, right? So it means less HCl and less gastrin. So there will be a no decrease gastrin mean decrease HCl and decrease action of parietal cell. To decrease action of parietal cell mean decrease HCl and decrease intrinsic factor, right? Also, okay, you are with me now. What's the question asking? The notice the colonization of the gastric antrum with the S shape gram negative bacteria. It is talking about So we'll discuss the in bacteriology. We'll discuss the H. pylori structure and how it is work, and we will discuss all the things of bacteria. And just remember for now that it's the shape S shape and gram negative bacteria is H. pylori. Right? For now,
Yep.
it is associated with the decreased number of somatostatin producing antral cell. What does it mean? Anything, any problem that is having anything that is present over here, right? That suppresses this somatostatin. Are you with me, guys? So this is being suppressed. I, are you with me, guys? They notice the colonization of the gastric antrum with the S-shaped bacteria associated with the decreased number of somatostatin producing antral cell. So I told you in the question number one that the H. pylori colonizes in the antrum part. Are you with me?
Yeah.
Yeah. So that antrum part have suppressed the D cell. The D cell has been suppressed. So what does it mean? So the D cell has been suppressed. Now there is a no negative inhibition. No negative inhibition. So gastrin has been increased. Okay. Also the ulcer has been increased. Also the parietal cell activation has been increased. So what do you think if the patient is having
That will be gastric ulcer.
gastric ulcer? Why gastric ulcer, doctor? Basically, the gastric ulcer present in the
Top
body and
body
the
fundus. Yeah.
yeah, it will be like that. It will be present over here.
Okay.
Okay, and the most part, the depletion of these cell in gastric antrum is most likely to cause which of the following disease? So, are you with me, guys?
So
Yeah.
duodenal ulcer, right? Duodenal.
Perfect. Yeah, perfect, perfect. Basically, what do you think about chronic pancreatitis? Is it associated with H. pylori?
No.
No,
Perfect. What about the gastric lymphoma? Is there any history of weight loss?
No.
Any predominant diseases that associated with the metaplasia and malignancy? That any problem in this stem?
no, sir.
Perfect.
No.
What about the vitamin B12 deficiency? How do you think?
There's no MCV, there's no megaloblastic.
Mhm.
Will not
No.
happen because there's enough HCl production, right?
Okay. So, what do you think about the gastric ulcer? Why not the gastric ulcer? And in
Because of the
Because
liquid.
the specimen was from the duodenum. They say it in the stem, right?
okay, yeah, yeah. I think you have got the answer that in the gastric ulcer, the most common type of gastric ulcer is your body, right?
Yeah.
If it is present in your proximal to duodenum, what will be your suspicion?
H.
Peptic ulcer.
pylori.
Yeah, peptic ulcer disease caused by two peptic H. pylori and
NSAIDs.
NSAID. So in this case, having a
Somatostatin.
H. pylori and there is that H. pylori lead to the decreased suppression of somatostatin and that causes the ulcer in the proximal part. Have got the point. So H. pylori is not associated with the gastric ulcer. It is mostly associated with your duodenal ulcer. Have got the point.
Sir, can you please comment on the vitamin B12 deficiency option?
Basically, in vitamin B12 deficiency, I told you that whenever there is a suppression of some D cell, right? So D cell have been suppressed. So the negative system have gone away. The negative have gone away. So there will be increased secretion of HCl, plus there is increased secretion of intrinsic factor. Okay, so this intrinsic factor and be releasing in a normal quantity. Okay, so that vitamin B12 will be came over here and it will absorb with intrinsic factor in the jejunum, right? So there is no any problem that causing an intrinsic factor problem. Whenever there is a vitamin P deficiency, there will be a problem that destroy the parietal cell and chief cells. And I have told you in the previous MCQs that is caused by autoimmune gastritis. Okay?
Okay. Thank you. Yeah. Thank you, sir. Got it. Thank you.
Okay, welcome. Basically, it lead to achlorhydria, megaloblastic anemia, and everything, and autoimmune gastritis. Autoimmune guy, whenever the H. pylori came, go to the duodenum and the proximal part of duodenum. Are you with me, guys?
Yes, sir.
Okay, perfect. Now,
I can go.
yeah.
This patient's bleeding is most likely a result of which of the following processes? A
Mm-hmm.
45-year-old man with diabetes mellitus is admitted to the intensive care unit due to community acquired pneumonia, septic shock, respiratory failure. 2 days ago, he developed fever, productive
Mm-hmm.
cough, shortness of breath that has progressively worsened. The patient is intubated and placed on mechanical ventilation. He's also started on IV fluids, broad spectrum antibiotics, and a norepinephrine infusion. On the third day of hospitalization, hemoglobin level drops from 14 gram to 12 gram. Nasogastric suctioning reveals bright red blood. This patient's bleeding is most likely a result of which of the following process?
Now discuss it. What the cause? Let me know that you can know the concept. I
As
have clear.
it's so you just mentioned a little time before that it is due to stress.
I think you have got the answer, and the patient is having going on the stress and giving a non-epinephrine infusion. Okay, have you got the concept for night now or not? I told you when there is a stress related, so the stress is a broad word for all the phenomena. You should know the stress, like you should know the patient is having a shock. Secondly, the patient is having a trauma. Third, you're having a burn and having a, and fourth, you're having a high bleeding. Okay, that all lead to the decreased volume, and that will lead to the hypertension. So that hypertension lead to the ischemia and most probably into the gastrointestinal form. Whenever there is ischemia, so that ischemia will lead to the destruction and ulcer formation in the gastrointestinal tract. Have you got the point
No.
or not?
Yes, sir.
Yes,
Yeah.
doctor.
Okay, okay. R2 parietal cell destruction will lead to, I told you, if there is a destruction of the parietal cell, you will be having a chronic gastritis or autoimmune gastritis. There will be, the patient will be having a achlorhydria and megaloblastic anemia. Okay, gastrin secreting tumor, the patient will be having a cause of the weight loss, everything. Okay, if the patient is having a granuloma formation, what do you diagnose will be if there is any sarcoidosis going on? Crohn disease. We'll discuss the Crohn disease in the further topics. Okay. And what about the Helicobacter pylori infection?
Duodenal ulcer.
Direct go to the duodenum and ulcer. Okay. Malignant transformation. Anything, any gastro malignant transformation. I think is not related to the malignancy. No, any weight loss, any anemia, it is duodenal shock. So what? I think you have cleared the concept.
That's
Are
stress.
you?
Yes.
Yeah. Are you with me, guys?
Yes, sir.
Yes,
Yes,
sir.
yes.
If you feel any question at any time, just stop me and ask the question. Okay? So basically, it's all you have to know that you have to read the stem carefully. So what's the going on? Okay, just know the bigger idea of the question. Okay, now go
Hello,
ahead.
hello, sir. Back to the previous question. Um, I know, but how would the stress be differentiated from iatrogenic injury from the intubation?
Intubation injury.
Let's say if there was an iatrogenic injury or iatrogenic injury as part of the answers,
Mm-hmm.
right? Due to because I think they said he was respiratory failure, productive cough, in place of mechanical. Patient was intubated, right,
Mm-hmm.
in place of mechanical. So how would that be differentiated? Because the intubation can also cause injury, and the patient we also see bright red. The blood might also come out. So how would that be differentiated in the stem, in the answers from this stress-related mucosal injury?
Okay, okay.
If
So,
if it was part of the answers to be chosen, yeah.
you are asking about the how will you differentiate between the mechanical ventilation related stress and the shock and septic shock or respiratory failure? Is this your question, doc?
No, my
Mm-hmm.
question is, iatrogenic injury due to intubation. If the patient is being intubated, there can be an iatrogenic injury.
Mm-hmm.
Yes,
So basically,
that can, yeah.
yeah. So in this case, basically there is a two type of the stress related ulcer, and let's discuss it in a little detail of this. What is the stress causes? So basically, you will having there are two type of ulcer that is due to the stress. Number one, that there is further divided into the Cushing ulcer and curling ulcer, right? So basically the Cushing and curling ulcer are basically, the curling ulcer and a Cushing ulcer. So Cushing mean to the Cushing word is indicating toward the brain, right? So you have to look at the if there is a high intracranial any disease that can cause an intracranial damage, any intracranial that cause a high vagal stimulation. That high vagal stimulation will increase the H plus. As you know that I told you that in the parietal cell, chief cell, and gastrin, the G cell. So this G cell is also stimulated by a vagal nerve. So if you increase the vagus, gastrin will be increased, HCl will be increased. So HCl will lead to the destruction of these mucosa, right? Also in the duodenal part. Okay, this is your question.
Okay.
In curling ulcer, it is divided into shock, shock, trauma, and burns, heavy bleeding. Okay, that all lead shock, decreased blood pressure, decreased blood pressure mean hypertension. Trauma mean bleeding loss. Burns, volume loss. Bleeding, volume loss. So it means the patient is having a hypovolumic stress. The hypovolumic means so there will be a,
The stress.
yeah,
Okay.
that distress will lead to the stress and related mucosa injury. This will be a local ischemia, that blood will not go to gastroenteritis. The blood will go to either brain, lung to compensate the cause. So the blood
In the
will be
heart.
less to the gastroenteritis. So you gastroenterology part, and you will be having ulcer over there. So
Okay.
it is not related to any mechanical ventilation and traumatic injury. Not if it is injured anywhere in the mechanical ventilation, it will also lead to mechanical ventilation can cause hypotension. So hypotension came over here.
Okay. Okay.
Okay, okay.
Okay. Okay.
Oh, yeah. So basically, mechanical ventilation and all the invasive type of like CPAP and BiPAP that also lead to hypertension, and also whenever the patient is on the dialysis. It also lead to hypertension. If there is having a severe hypertension during the dialysis and a mechanical ventilation invasive form, so they always causes hypertension. You have to know that what is the cause of hypertension. So that hypertension will lead to the local ischemia, and the local ischemia will lead to the ulcers. Okay, just focus on the very high yield points, not that in depth. Okay, just high yield points are important, like shock, trauma, burns, and heavy bleeding, right?
Okay, thank you.
Okay, welcome. So, any new volunteer?
Yes, doctor. Answer the question. Which of the following is the most likely pathogenesis of this patient esophageal condition?
Mhm.
So 32-year-old man come to the office due to intermittent dysphagia for solids and liquids. He has no significant past medical history and doesn't use tobacco, alcohol, or illicit drugs. His father has a history of esophageal squamous cell carcinoma. Physical examinations are remarkable. The patient undergoes an esophageal manometric study that demonstrate periodic, simultaneous, and non-peristaltic contractions of large amplitude and long duration. Which of the following is the most likely pathogenesis of this patient's esophageal condition?
So, basically, in this case, the patient is undergoes visual manometry study that demonstrate periodic, simultaneously non-peristaltic contraction, large amplitude for longer duration. What do you think if the patient have a constant and non-peristaltic constriction of this esophagus? Okay, let's discuss it. Let's discuss. Disruption of a gastroesophageal junction. What do you think? I told you. This is your esophagus. This is your membrane. Okay, and this is your stomach. That membrane is called your diaphragm. Okay, is a membrane called phreniodiaphragmatic membrane. So any disruption in gastroesophageal junction will lead to that disruption will lead to the hernia in disruption. Okay, so the stomach will be present into your diaphragm. Okay, like this. Okay, but there will be a peristaltic, non-simultaneously, and low amplitude contraction that is present like that. When let's discuss a normal contraction of esophagus. Basically, this is your esophagus, right? When you eat your bolus over here, right? So this part contracts, upper part it contracts. Okay, the lower part relax. So the food can push to down, right? Like it will be present like that. Food is here, this is contracted, and this is relaxed form. Okay, so food is pushing downward. Okay, so in this case, the patient is having a demotion periodic, simultaneously non-peristaltic. This is called peristalsis, contraction and relaxation, contraction, relaxation. So periodic contraction, peristalsis, and low amplitude. So what does it mean? So the food will be go downward. Have you got the normal phenomenon now? If there is a disruption of esophageal junction, like this is disrupted, so there will be esophageal hernia. So sorry, the stomach hernia, gastric hernia. So the gastric hernia will lead, so there will be a no changes in the esophagus in manometry. Okay, in esophenic infiltration, there is an esophenic esophagitis. So that will lead to inflammation, and that it's not with this any finding of the monument. It is not specific with eosinophilic esophagitis. Is present with a reflex GERD that lead to the reflex esophagitis and having also dysphagia, right? Impaired neural inhibition. What do you think that the patient is having an impaired neural problem? So if there is a problem over here, if there is a neural problem, there will be a strong contraction. Okay, so there will be a very strong contraction, and that cannot be revealed, and that will be a high amplitude, and that will be a non-peristaltic. Okay, mucosal outpouching through a muscular defect. I think it is talking about the zinca diverticulum. So zinca diverticulum is also a muscle weakness, but it is not associated with your esophageal manometry. The most important test we do for the zinc and diverticulum, you have to bury swallow. You have to bury swallow that that will lead to the that patient present with this will be having a dysphagia, halitosis, and food regurgitation. Right? Obstruction from unregulated cell growth. If there is any growth over here and any growth over here, right? So what do you think? What will be the patient presentation? There will be dysphagia of food. First will be food problem, the gastric esophageal carcinoma, right? After that, it's also be liquid problem. Cannot take a liquid, right? And also there will be the loss of an weight loss, and so it is included with your alcohol and tobacco use. Okay, if it is present with the good, it will be a barodophysicus over here. Now, if a patient is having, all right, this distal part of esophagus is the proximal part. Let's discuss the esophageal cancer. The proximal part of the esophagus is associated with your squamous cell carcinoma. Okay, and the distal part is associated with your adenocarcinoma. High yield and most important point. Okay, in both the cases, there will be intention weight loss. First, dysphagia to food or solid material, then after followed by a liquid. Okay, now smooth muscle atrophy and gut wall fibrosis. You have to tell me what the disease? Fibrosis,
Systemic sclerosis.
systemic sclerosis. Perfect. So, what's the cause and what's the disease over here? What do you think? That cause a spontaneously non-peristaltic large
C.
amplitude construction. What do you think?
It's impaired neural inhibition.
I think everyone have cleared the concept or not. Everyone, what will be the monometric test in systemic sclerosis? What do you think? What do you think in systemic sclerosis the monometry will be? There will be less contraction as compared to normal. For example, I think you have cleared the concept, yes or not? Everyone, can anyone
Yes.
hear me? Yeah. So in systemic sclerosis, there is atrophy and fibrosis of muscularis rare. So there is no contraction and no relaxation. Okay. So there will be a relax. If the food present, the esophagus will be relaxed. So for example, this is your monometry and this is your tone present over here, right? This is your pressure over here and this is your time. So like this is your normal pressure over here. Okay. This is your normal pressure. This is a normal graph. In your impaired neural inhibition, mean the neural inhibition, the myenteric plexus is not working properly. So there is a strong non-peristaltic contraction that lead to the collapse or the problem that lead to the continuous contraction of esophagus. So the pressure will be high. So that is pressure. The pressure will be high air there. Okay. So what happened in the systemic sclerosis? The systemic sclerosis, there will be the muscularis fibrosis, so that will lead to the decreased contraction or decreased pressure in the monometry. It will be present over here. The pressure will decrease. It is, for example, 2, it is 5, and it is 10. Have you got the point? Have you got the concept? No any relation of monometry with the gastric junction, any insufficiency features, mucosal outpouching, and any carcinoma. It is not associated with these things, monometry, but it is associated with the neural inhibition and mucosal atrophy and gut fibrosis. Have you got the
So is
point?
it achalasia cardia, sir?
No, no, no. It is not an achalasia. In achalasia, the problem is in the distal part of the esophagus. You will be having a distal part problem. Okay, it is basically the spasm of the whole esophagus. Basically, this is your esophagus. The whole esophagus is contracted.
So is it Barrett's
Even
esophagus?
in
No, 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 no. I
even
think
in achalasia, we'll be seeing increase in pressure loss, sir, manometry.
yeah, increase monometry at the distal point, not
Only at
whole.
distal point.
Only at distal point,
Okay.
right? In achalasia,
Okay.
there will be the. It is the whole. The is demonstrate periodic simultaneously non-peristaltic contraction large amplitude duration of the whole esophagus is talking about. Whenever it comes to achalasia, you will be having a very esophagus of the bird beak appearance. Number one in achalasia.
Okay.
Okay. Secondly, the visual monometry will be having a strong contraction at the distal part.
Okay.
Okay.
Okay, sir.
Right, perfect. So you know the three more main important thing. Number one, if the patient is having this disease is mentioning is diffuse esophageal spasm. Whole esophagus is spasm due to the impaired neural inhibition. Okay, so in the diffuse esophageal spasm, the whole esophagus will be contracted, and there will be the whole contraction of food. Okay. Now, what will happen in the systemic sclerosis? The systemic sclerosis, the pressure of the esophageal will be decreased as compared to normal. What will be in achalasia? In achalasia, there will be a distal esophageal monometry will show high amplitude contraction. Okay? Okay, guys.
Yes.
Yeah, basically, yeah, this is the diagram. Now, let's discuss if the normal. This is the normal sequence, and this is your contraction. Now, if the food is present over here, for example, if the food is present over here, right? So this pressure sense, this will be contracted like this and this will be relaxed. So there will be a high speed contraction over here and this is relaxed. Okay, now the food came over here. So this part will be contracted, the above part is contracted, so this like that, and the previous part like this part is contracted in this part, and the previous part has been relaxed as shown in this diagram. This is previous part, this is the contracted form, and this is the relaxed form. Okay, now when the food came over here, so all the previous part have been relaxed, this is being contracted present over here, and this is also relaxed present over here. Have you got the point? Contracted, this is relaxed. Okay, this is your normal sequence of the esophageal monometry. Whenever there is a complete spasm or no neural inhibition, no any stimulus that inhibit, so they will all stomach will all esophagus will be having a diffuse spasmatic stage. So it should be like that. It should be like that. It should be like that. Okay, it should be like that, and it should be like that, and it should be like that, like this contraction. Okay, but what happening is it whole esophagus is spasmatic at one simultaneously contraction. Have you got the concept? Everyone?
Yes.
Yeah. So basically, in the diffuse esophageal monometry, You have to notice the important thing that what will be the echinacea, what will be your systemic sclerosis, what will be your diffuse spasmodic esophagus and systemic sclerosis esophagus and echinacea. You have to remember the point. Now, anyone can go to the next MCQs. Any volunteer? Almost 34 students are there and no one is responding.
I can do it if nobody else is there.
Okay, I can read. No problem.
Okay, why are
This is
no? Okay, the new students are not interesting, or they are boring. What's happening? Or they are not enjoying the point.
No, some people don't like to read.
Uh, 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 but the point you all are understanding the points or not? The point is that.
Yes, we are.
Okay, 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 okay,
Okay.
okay. Yeah.
Bio- Biopsy of which of the following sites is most likely to demonstrate the infectious agent responsible for this patient's current condition? A
Okay.
34 a 34-year-old man comes to the office due to upper abdominal pain. Oh, I'm sorry. The patient
Okay.
hold on, hold
Go ahead, doc.
Okay, sorry. Okay, the patient has a vague discomfort that happens mostly in the afternoon and at night,
Hmm.
and is partially relieved by food.
Okay.
Mhm. He sometimes feels nauseated.
Hmm.
He has had no vomiting black he has had no vomiting, black or bloody stools,
Okay.
or weight loss. The patient takes no prescription or over-the-counter medications.
Hmm.
Family history is negative for cancer.
Hmm.
Upper gastrointestinal endoscopy reveals a small ulcer with a clean base in the duodenal bulb.
All
Biopsy of the following site is most likely to demonstrate the infectious agent responsible for this patient current condition.
what do you think? Give me the answers.
I know it's the duodenum, but I'm trying to figure out whether it is
No,
up.
wait a minute, wait a minute, wait a minute. Try to understand the question.
Okay.
The ulcer is present in the duodenum, right?
Yeah.
And is the bulb of duodenum. The bulb of duodenum is the proximal duodenum.
Yes.
Okay. So biopsy of which of the following site is most likely to demonstrate the infectious agent responsible for the patient current condition? So which is the infection agent?
That would be that would be H. pylori.
Yeah, H. pylori is the infection agent, and I have told you the H. pylori colonizes in which part of the stomach, and I have made a diagram over here as well. Doctor, are you understanding the point or not?
Yes, I do.
So have you clear the concept? So the problem is over here. They're not asking about the ulcer. They're asking about the infectious agent, where
Infectious.
the infectious agent colonizes. Have got the point?
Yes, I do. Yes.
And also, I told in the history when the difference between a gastric ulcer and a peptic ulcer, the peptic ulcer is relieved with food. No
Yes, the
vomiting,
pep.
no vomiting, no vomiting, mean no any problem in GIT, no black, no black and bloody stools, having a no lower. lower GI bleeding, no weight loss means no malignancy. The point is not to diagnose this time. The point is where the infection is responsible from the current condition. Have you got the point?
Yes, sir.
So where the H. pylori colonizes. So can you give me the answer? Can you give me the answer, doc?
The
No.
antrum?
Perfect.
The
So
antrum.
wow. So let's discuss the cardiac anatomy to that you know the crystal clear of the concept of the parts of the stomach. So basically, let's discuss the part of the stomach so that you can understand what's the problem is. Basically, this is your discuss in the detail that you don't forget and not me. Okay. So basically, whenever this is your fundus, right? The whole from this up to this. Got it right? And from this notch and over here is your entry. Alright? And important thing over here that a diagram is not that good, but is cardiac present over here. Right? Fundus, body, and antrum. Parietal cell, chief cell, and antrum, you feel the G cell, D cell, and G cell. Okay, so the most of the part where the H. pylori colonizes in antrum. Okay, you got the point or not? So remember, whenever the points came where the H. pylori colonizes, the point will be a gastric antrum. Right? What is the problem in the gastric body? You will have to get to know autoimmune gastritis. Okay, or not? If the patient is have a lower duodenum, so ulcer is present in lower duodenum. Sorry, the any tumor in lower duodenum like gastrinoma and like that. And it's the upper duodenum, the peptic ulcer disease, the ulcer will be present and duodenal ulcer. Okay, but the bacteria resides in gastric anthion. If the question was about if H. pylori is causing the duodenal ulcer, so which part of duodenal ulcer? It will be your upper part. So the question is not. Question is asking about which infection agent is responsible. The infection agent is responsible in H. pylori, and where it colonizes in the gastric antrum. Have you got the point?
Yes, doctor.
Thank you. Now, any volunteers want to read the question?
So in that question, sir, so the ulcer is in the upper duodenum, but the question was where's the H. pylori mostly located, which was the antrum.
Basically, the biopsy of which of the following sites is most likely to differentiate the infectious agent responsible for this patient current condition. Okay. The question is asking about where the H. pylori resides and colonize. Okay.
Okay, yeah.
The most important point over here is the
What is
antrum.
that? Antrum, yeah.
Okay.
Okay, sir. All
Thank you.
right. Thank you.
Welcome. So, any question over here? Now, go ahead with it.
Which of the following stimuli is most likely cause of parietal cell proliferation in this patient?
Hmm?
32-year-old man comes to the clinic for peptic ulcer disease follow-up. The patient has received several months of proton pump inhibitor therapy without significant improvement in his epigastric discomfort. He does not use NSAIDs, tobacco, or alcohol. H. pylori testing is negative. The patient undergoes a partial gastrectomy for refractive peptic ulcer disease. The pathologist receives the tissue and notices significant enlargement of the gastric rugal folds on gross examination.
Hmm?
Microscopy of gastric mucosa reveals parietal cell hyperplasia. Which of the following stimuli is most likely cause of the patient proliferation in this patient?
Wait a minute. Okay. The question is asking about there is a microscopic gastric mucosa reveal parietal cell hyperplasia. So can anyone tell me no use of NSAIDs and H. pylori is negative. So I think duodenal ulcer is excluded, right or not?
Right, sir.
Yes.
The patient is doing PPIs. Important thing over here. PPI, proton pump inhibitors. Now let's discuss a little detail. In which part of the stomach parietal cell present? Which
Body
part?
does.
A.
On the sun.
The first
Fundus
response.
and body. And in the microscopic, there is a hyperplasia of parietal cell. I think it will be a more in number. The hyperplasia. But the patient is using PPI. What does the PPI do? PPI inhibit this proton pump. Basically, this is your lumen. This is your so the in lumen they protect the hydrogen come in the stomach lumen and the potassium away from the lumen, right? So this causes acidity. So whenever you block this, okay, so these proton pump are not secreting HCl in stomach due to PPIs. So this PPI causes inhibition. For example, let's discuss it a little more detail. For example, you are having a one parietal cell over here, right? That causes H plus. Okay, you give a PPI, so that this this proton is inhibited. Now the most important thing come on here. What's this cell? Chief cell, right? What's this one? G cell.
G cells.
And what this cell? D cell. Okay.
Okay.
So if there is a decrease H, less H in stomach due to PPI, so the gastrin there will be less acidic in environment in stomach. So G cell will release a gastrin to stimulate this parietal cell, right? So as you know, this parietal cell is blocked. So where the gastrin work, gastrin will promote another parietal cell to come. Okay, so that parietal cell will release H positive. It will be also inhibited by this PPI. Are you with me, guys, or not? Are you getting a
Yes,
little
doctor.
Yeah. Okay. So if one is blocked by this and another is blocked also by this gastrin will again release and again stimulate the parietal cell. So more acidic. This will be also blocked by this. Okay. So this gastrin is causing the hyperplasia of the parietal cell and these parietal cells are blocked again by the PPI. Are you getting the concept?
Yeah.
Yeah.
Yes,
So
sir.
basically, the patient is using the PPI. So the PPI or work on a parietal cell. So no ICL in the stomach. So gastrin have receiving the signal that there is a no HCl present in stomach. So why there is no HCl? So gastrin releases and activating the parietal cell. The parietal cell inhibited. So it causes the parietal cell to regenerate. So regeneration cause the hyperplasia of the parietal cell. I got the point. I have told you
Yes, sir.
I told you that this is also stimulated, this parietal cell are also stimulated by two way. Either vagus nerve stimulate the gas G cell and G cell stimulate gastrin. So it almost the gastrin. Another short say the enterochromaffin like cell, okay, it is also stimulated
Three.
by
Gastrin.
yeah, it is also stimulated by a gastrin. So that will also release the parietal cell. So what is the main stimulus for the
Even
hyper?
acetylcholine also stimulated parietal cells, sir.
Yeah, acetylcholine can increase this vagus nerve. Okay, so that vagus will cause the G cell. That G cell will there cause a gastrin to release, and that will gastrin will cause the parietal cell. Okay, are you with me, guys?
Yes, doctor.
Basically, the path of the parietal cell activation is three. Number one, through G cell, gastrin. Another gastrin, right? Another one is enterochromaffin cell, but it is stimulated by a gastrin. So gastrin stimulates enterochromaffin cell. Enterochromaffin cell release histamine. That histamine is released, they act upon the parietal cell and causes proliferation. Okay. Another is through a vagus nerve. Okay. So yeah, doctor. Yeah, perfect. I'm coming over here. This vagus is also stimulated if we give acetylcholine. So acetylcholine release a vagus. So this vagus stimulates the G cell. This G cell again stimulates the gastrin. The gastrin then causes the hyperplasia of this parietal cell. Are you got the point, doctor? Everyone, I clear the concept.
Yes, doctor.
Yeah, perfect.
Yes.
Basically, to know the common pathway is gastrin. Whenever you activate a vagus nerve or enterochromaffin cell, the main culprit is gastrin. Okay?
Okay.
Yeah, perfect. Now, any volunteers? Any volunteers?
Let me read.
Okay, go ahead.
This test results suggest that which of the following processes is occurring. A
Mm,
56-year-old man comes to the office for evaluation of upper abdominal pain, occurring with meals for the past month. The symptoms improve when he is fasting. The patient has a history of coronary artery disease and osteoarthritis. Current medications include aspirin, simvastatin, and acetaminophen is needed. He drinks
mm,
one or two beers daily, but does not
mm,
use tobacco or recreational drugs.
mm,
Upper endoscopy reveals a gastric ulcer with a smooth, round border and an exudative base. A,
mm,
bi- a biopsy specimen of the ulcer is placed into a solution containing urea and phenol red, a pH indicator. 30 minutes later, the solution turned pink, indicating a pH increase. This test result suggests that which of the following processes is occurring.
yeah, perfect. Basically, there's ulcer over here. Okay, so they have biopsied this ulcer, okay, and paste it in a tray. This biopsy is spread over here. Okay, a biopsy specimen present into the containing of urea plus having a urea, okay, plus a pH indicator and the phenol red. Okay, now this turn into this specimen after 30 minutes. This specimen turn into pink, pH increases. This test result suggests which of the following. So, the most important thing to know the test of the basically the patient is having acetaminophen usage, right? Okay. Now, when the symptoms improve when he is fasting, it means whenever he eats, he feel a pain. So the pain is likely due to a gastric ulcer. Okay. So the biopsy of this specimen, there's a gastric ulcer, and the specimen is placed in the container having a urea, pH, and a red phenol. After 30 minutes, it changes the run a color in pink and increase pH. Okay, and pH increases. So this test indicates which of the following result would be your. Now, the important thing to know, the important thing now let's discuss on the basis of this cyclooxygenase inhibition leading to mucosal damage, but it cannot be detected in the this cyclooxygenase has no activity on this urea. So what does it mean? The pH has increases. So anything that is present is base. Okay. So cyclooxygenase has no impact on the urease. Whenever you put a urease, okay, on for example the urea, whenever a urease enzyme act on it, it disintegrated into carbon dioxide plus NH3. So this NH3 give us increase the pH, okay, and also give us a pink color, and this carbon dioxide evaporates. You got the point. Now, cyclooxygenase has no effect on this urea. It just affects the cyclooxygenase pathway. Whenever cyclooxygenase pathway inhibit the prostaglandin E2 decreases, thromboxane E2 decreases. Thromboxane E2 decreases having any inhibits platelet degradation causing bleeding. If a prostaglandin E2 and I2 inhibits, there will be a no mucosal protection, there will be a gastric ulcer, right? What about this enzymatic production of ammonia? What do you think? I put a urea and I put a any specimen from the biopsy that causes this urea to change in ammonia plus CO2. Okay, are you guys getting the concept? What happened in the gastrin releasing gastrin hypersecretion lead to acid overproduction? So what do you think? This it causes,
Low pH.
yeah, there will be, if there is a gastrin like gastrinoma is present, right? Gastrin hypersecretion leading to acid production. So there will be a low pH. Perfect. Parietal cell destruction due to autoimmune disease If there is a destruction of the parietal cell, so what will happen? The patient will be having the most important thing. I told you, whenever there is a most important thing, that will be your decrease HCl and decrease intrinsic factor.
It's a factor.
Perfect. So achlorhydria and megaloblastic anemia. There is any detailed conversation, any of megaloblastic anemia and anything in this time? No. Okay. And in this condition, it has no effect on the urea as well because it is destruction of the parietal cell. No any changes in the urea cell. Okay. So what's the clonal proliferation of glandular cell? So this is the adenocarcinoma. Glandular cell adeno, and it is the proliferation that is carcinoma. Have you got the point? So that adenocarcinoma present will be due to any history of the weight loss? No. No history of the weight loss. No any, I told you, lower esophagus, upper esophagus squamous cell carcinoma, lower esophagus adenocarcinoma, the Barrett esophagus. So any there history of the chronic reflex history, GERD, gastroesophageal reflex, any history of heartburn for many years, any history of the metaplasia, weight loss, anything else? No. Are you getting the point?
Yes, sir.
Yeah. So this is the point, the enzymatic production of ammonia. So there is a specimen that causes this urea to convert it ammonia and carbon dioxide, and that specimen is called H. pylori. So H. pylori contain enzyme that is called urease, and it is also the H. pylori can be also be tested through your blood test, through your breath test, through your stool test, or the last one to take the biopsy of that specimen and put it. It is the very least common and not least common test present present in this specimen, and add a urea, pH, and red phenol. This specimen will cause this H. pylori causes increase in pH due to ammonia, carbon dioxide evaporates, and that will lead to the pink color of it. Have you got the point? Have you excluded all the questions? Everyone?
Yes, doctor.
Yeah,
Yeah.
perfect, perfect. So basically, yeah. So just focus on the point that what's the option is causing about, and the no, I we have learned many things about H. pylori. Let's summarize it. H. pylori is the most common cause of duodenal ulcer. Number one. Duodenal ulcer is caused by 95% H. pylori and 5% NSAID. Number one. Secondly, the H. pylori colonizes in the gastric antrum. Okay. Third, the H. pylori is S-shaped gram-negative bacteria. Okay. That gets H. pylori also causes the decreased production of somatostatin, and that can lead to the ulcer due to the no inhibition of gastrin. So gastrin have hyperactivated, that will lead to the acid that will be causing the ulcer. Are you got all the points of H. pylori? And the last point, from the previous MCQs, the H. pylori secrete a urease enzyme, and that urease enzyme causes the urea breakdown and lead to NH3 ammonium and carbon dioxide. That ammonia causes the pH to increase and acidic basic environment. Have you got all the points of H. pylori in one page?
Yes, doctor.
Okay, perfect. Now, yeah, yeah. Any volunteer want to read the question?
Yes, sir. Which of the following factor is most directly related to the pathogenesis of the patient's current condition? A
Mhm.
35 years old man with a history of alcohol use disorder is brought to emergency department with hematemesis. Prior to this, he has 3 episodes of vomiting. His blood pressure is 110 by 80 and pulse is 98. He has no jaundice. Lungs are clear to auscultation. Abdomen is soft, non-tender and non-distended and no hepatomegaly. Endoscopy show longitudinal mucosal tears at the gastroesophageal junction. Which of the
Perfect.
following is most likely directly related to the pathogenesis of the patient's condition?
Okay, okay. The patient is having an episode of hematemesis, blood in the vomitus, okay, and a 3 episode of vomitus, right? Lung concentration are normal, no jaundice. No jaundice means there is a no cause of the liver, right? The abdomen is soft, not tender, not distended, and mean there is a no any portal hypertension, no hepatic vein thrombosis, no hepatic vein, no portal vein thrombosis, right? No hepatomegaly, all right? Endoscopy reveal longitudinal mucosal tear at the gastroesophageal junction. Which of the following factor is most likely pathogens? I told you in yesterday class that if it's tear, tear of this mucosal layer, what do you think? What the tear is caused by the strong vomitous hematemesis? Are you with me, guys?
Yes, sir.
Yeah, basically there is a tearing. The tearing is of two type. Basically, let have this is your whole esophagus, right? Mucosa submucosa muscularis adventitia, right? Now, there is a two injury of the gastroesophageal junction. Let's clear this MCQs first, then we go to the detail of this tearing, okay? Is there the venous pressure? What do you think? What is the problem in it? If there is increased venous pressure, so the heart,
Varicose esophageal varices.
yeah, yeah, very sis, right? So any history
Yes.
of portal hypertension,
No,
cirrhosis, anything else?
no, sir.
What about the local inflammation? Like esophagitis can esophagitis can cause bleeding? Upper GI bleed? No. It's just the inflammation of esophagus. It will not cause the bleeding. Okay? And what about acid? If the acid goes up, it will change the structure of this epithelium but does not cause the change to bleed. What about the mucus ischemia? So whenever there is a ischemia, either due to your curling or a Cushing or due to any thrombus that can cause or due to the low cardiac output, there will be ischemia. But that ischemia will lead to ulcer, and that ulcer will cause a bleed. But how will it be differentiated from this condition? Is there any history of shock? Is there any history of a trauma? Is there any history of a bleeding? Is there any history of everything that can cause? lead to? The blood pressure is almost normal, so I think there is a no shock. Okay, and no shock mean no hypovolemic shock. Okay, if there is hematemesis present, but that hematemesis is not that severe to cause the hypovolemic. Have you got the point? So there will be a no hypotension, right? So no hypotension mean no mucosal ischemia to the GI tract. Have you got the point?
Yes, sir.
Perfect. Increase in intra-abdominal pressure. Yes. Why? Hematemesis. 3 episodes of vomiting are strong. There will be the increase in intra-abdominal pressure over here in this part, and that will tear this mucosal, and that will lead to a bleeding. If the patient come to your department having a strong vomitus history and there is a no any history of no complaints of shock, low BP, no anything condition, just only presentation is vomiting and the plus having a fresh blood in the vomitus, hematemesis. Your topmost diagnostic differential diagnosis will be
Tear.
Increase intraabdominal pressure.
sorry, increase your blood pressure. Now, what will be the suspicion? The suspicion will be
Mucosal
your
tear.
mucosal tear. Mucosal tear. Now, let's discuss the tearing. If we take the, for example, this is your esophagus, right? And this is your mucosal layer. Submucosal layer, muscularis layer, and adventitial layer. There is all the layer of esophagus. Okay. When the patient is in a normal condition, right? Are you with me, guys?
Yes, sir.
Yes, doctor.
No, any history of anything. If there is only a forceful reaching vomiting that will cause this only the tear of this mucosa. Have you got the point? The tear will be out there. So the blood will be ooze out from here like this. And this is called the Mallory
Means tear. Syndrome.
West syndrome. Number one, only the mucosal layer is damaged in this case. Okay, the damage to the will be your other submucosal and like this. Now, the presentation will be hematemesis, right? Plus heavy bleeding, heavy vomiting. Sorry, no bleeding, heavy vomiting, right? Are you with me, guys? Now,
Yes, doctor.
and another condition that causes the tear of the whole esophagus.
Full
The
thickness.
bleeding will be from here to like this. Transmural damage.
Mm.
What's this?
Would have.
Borhave syndrome. Perfect. Borhave syndrome. Perfect. So, what will be the clinical difference between these two differential? Number
Hyper.
one. Perfect. Number one, all the material from the esophagus, either air or fluid, will be go to your mediastinum. Okay, number one point. And the patient of the mucosal tear of full transmural and full transmural damage, the patient will be presented in the history of either shock, it will be unconscious patient. Number two, The patient will be having a difficulty in swallowing, difficulty in a very heavy pain in the chest, back, and epigastric strong pain. Okay, and if you have a chest ray of this patient, you will find a pneumothorax, air in the thorax. So we have discussed in the pulmonary section, whenever there is air present. So what will be your resonant sound on the percussion? What will perfect? And what about the tactile fremitus? It will be
Reduced. Reduced.
tactile fremitus will be
Reduced.
perfect. To tactile fremitus, the percussion and decreased breath sounds, and the patient will be in the unconscious condition. Have you clear the difference between the Mullary-West syndrome and the Borheim syndrome?
Yes. Thank you, doctor. So,
Perfect. So basically, you have to clear the concept between the most important thing, the Borheim syndrome and the um, Murray-West syndrome. It is, I think, 1 to 2 MCQs will came from these topics, and you will remember me at that time. Now, go ahead. Any new volunteers? Any
Can I read?
volunteer? Yeah, and I think no volunteer left, so you can go. I think I'm teaching only to 2 or 4 students.
Which of the following developmental
Hmm.
defect most likely underlies this patient condition? A 5-week-old boy born to 23-year-old primary gravida is brought to emergency department due to increasingly frequent forceful vomiting after every feed over the last 4 days.
Mhm.
Emesis appear to be undigested formula. The patient seems hungry again after vomiting. On examination, the interior fontanelles are slightly sunken, mucous membrane are dry. Abdominal examination show prominent peristalsis in the epigastric region. Laboratory evaluation indicates metabolic alkalosis and mild
Mhm.
unconjugated hyperbilirubinemia. Which of the following developmental defect most likely underlies this patient condition?
So basically, yeah, okay, perfect. What does it mean?
It's
Dehydration?
dehydrated because he's vomiting, so there's
Perfect.
dehydration.
Dehydration is due to frequent forceful vomiting after every feed. Okay, you got the point. Examinations show a prominent peristalsis in epigastric region. Now, the point came over here. This is your esophagus, and this is your whole stomach, right? You divide it into that part. Whenever you take in the epigastric region, there's a high peristalsis movement over here, and laboratory indicates metabolic alkalosis. So metabolic alkalosis is due to
Severe
vomit
vomiting.
perfect.
of the
So yeah, in vomiting, the acid remove out of the body. So there is a no acid present in body. So it means there will be a high base. So that will be alkalosis. So that is caused by not the respiratory cause, it is the metabolic cause. So it will be a metabolic alkalosis. Okay, we will discuss the metabolic alkalosis and EBG is compensatory. I have Dr. Hashim is discuss these topics very well in the renal system. But if we make a time, we'll discuss it again. But for now, it's not our concern. Our concern is that what causes and this strong peristalsis. Either the vomitus in bilious is no, or non-bilious. Is it mentioned in the stem or not? Basically, The most important thing in the patient of this is the age as well. I forgot the age. 5-year-old boy. Okay. So there is a known bilious vomiting, right? If the bilious is present, then it will be a bilious. If it no vomit, just vomiting, so it is 100% confirmed that it is a non-bilious vomiting. So what's the cause? The cause is this is your ampoule of water. The cause is above this ampoule of water. The cause is over here, right? Now come. There is increased peristaltic in epigastric region. What does it mean? Whenever the patient eat food, it's remain in stomach. The stomach contracts strongly and there is a high peristaltic movement over here, and this food cannot go out through this inlet. Okay, so it goes backward in vomit. I got the point. So I think the abnormality from this stage came to this stage. Are you with me, guys?
Yes,
Yes,
sir.
sir.
Yeah, yeah, okay. Now, now come to the question. What's the question? Abnormal gut rotation of the midgut. So if it is present in the midgut, okay. So what do you think? The vomitus will be of
Bilious.
Bilious.
perfect. Cystic dilatation of a biliary tray. What do you think? And what's more important thing over here? Metabolic alkalosis. Wait a minute. And mild unconjugated jaundice.
Mm.
Yeah, a point. Jaundice, conjugated, unconjugated. The conjugation take place in liver, right? If you see a patient having a jaundice and you test and let, let do the serum bilirubin and you find the patient is having a high serum unconjugated bilirubin. So what does it mean? Let's discuss in detail. This is your liver. The bilirubin is our hair. This is unconjugated bilirubin, right? This goes into liver and conjugate our liver and then goes into the bile in a conjugated form, right? If the unconjugated bilirubin in your serum bilirubin is high, it means the bilirubin it is in blood, right? So unconjugated bilirubin is high. What does it mean? The problem is
Red blood cells.
in blood, not red blood cell. In any vessel, basically it is three type. It is not prehepatic, hepatic, and post-hepatic. Prehepatic, hepatic, pre. So whenever there is an increased unconjugated bilirubin, so the cause is present in the prehepatic, and the cause is either hemolysis going on in the blood that will lead to increased unconjugated bilirubin. Okay. Now, if there is a high increase in serum conjugated bilirubin, so it means the problem is not in blood. Either the problem is in liver or the problem is in the biliary tree. Okay, hepatic and post-hepatic. Now, if you see it as alkaline phosphatase high, either a problem that is in the biliary tree. We will discuss LFTs and further topics in the liver in hepatology, but for now, just come to prehepatic, hepatic, and how will differentiate. If unconjugated is high, unconjugated high prehepatic, the cause is in the cause is in the blood. Either hemolysis is going on now. If conjugated is high, the problem is either hepatic and post-hepatic. Now, whenever you see the test alkaline phosphatase, is it high? So you have exclude the hepatic cause. Go with your biliary tray. Now, if you are having a normal alkaline phosphatase and ALP alkaline alanine transferase and IGPT are high, so the cause is your hepatic cause, either hepatitis, autoimmune hepatitis like that. Okay, so cystic dilatation of a biliary tree mean there will be the high which type of bilirubin?
Conjugated.
Conjugated bilirubin. Perfect. Disruption of the mesenteric blood supply. What do we think if there is a disruption of mesenteric blood supply? So that will lead to if there is a
Regional atresia.
yeah, that will be a do don't know. This is not a
Jejunum.
Yeah,
Jejunum and ileum. Yeah.
okay, sorry. So ileum and jejunum atresia. Have you got the point? So ileum and jejunum atresia, the vomiting will be of which type?
Bilious.
Perfect. If there is a fibrosis of obliteration of extrahepatic bile duct, so I think the bile has stopped. So which bilirubin will be increased? Come on, guys.
Conjugated.
Conjugated bilirubin. Have you got the point? And the last option we have left is abnormal growth of smooth muscles. So what does it mean? It means simple. There is an oval growth in the pylorus region. So there is a high food present in the stomach. That stomach causes peristalsis, and this food cannot go out of it. So no blood, no emesis, no bilious vomiting. So there is a high blood hypertrophy in pylorus region. So this food will go out. So the patient feel hungry after each feed, and after each feed it feels hungry, and after. Have you got the point? Have you got the concept? Everyone.
Yes,
Yes,
So
sir.
can
doctor.
we go the option D and E, please?
Basically, in option D, if you go with the option D, we have discussed if there is an problem here. We have discussed in the embryology section. Basically, there is a two type of atresia in the GIT. Atresia, right?
Mm-hmm.
Either it is a duodenal atresia, either it's a ileum or a jejunum atresia. Okay?
Okay.
The point here is to that, so which embryological phenomena lead to the duodenal atresia and which phenomena lead to the jejunum and ileum atresia. The high yield and most important and most tested is that the failure of the recanalization of the tube will is the phenomena that lead to the duodenum atresia. For example, this is your duodenum, right?
Yes,
First
sir.
part, second part, third part, and fourth part. There is a no recanalization over here.
Yeah.
Okay, so there will be atresia over here, right? So atresia will be of like that.
Oh,
Okay,
okay.
so what's there is a recanalization problem. The important word is recanalization, failure of recanalization. What's the phenomena ileum and jejunum? Helium and jejunum. The important phenomena is the mesenteric ischemia. Whenever There is ischemia to ileum and jejunum without an embryological state. For example, this is your ileum and jejunum, okay? And there is a blood supply that there is ischemia over here. So there will be a no blood supply in this part of the jejunum, right? So there
Yeah.
will be atresia over here.
Oh.
The phenomena is there will be ischemia. That ischemia lead to necrosis, and that necrosis have then go with atresia of. I
Yes.
got the point. Ischemia
Yes, sir.
and recanalization. Ischemia in ileum and jejunum, and recanalization in duodenum atresia. If you want to go more details, go and see our gastroenterology embryology. You will better clear the option. But I think I have gone through the high part.
Yes. Yes, sir.
Okay.
Thank you so much. Appreciate it. Yeah.
Welcome. You are
Thank you.
welcome. Welcome. So basically, in this condition, you have on the basis of exclusion, you have excluded B, C, D, and E, and you have left with option A, and I think you have got your answer. Okay? Yeah, basically the patient was having an infantile pyloric hypertrophy. Okay, now go ahead with this next question. It's almost late. We can move a little fast. Now,
Which of the following was the most likely cause of this symptom? A
uh,
53-year-old man with,
mhm,
with nocturnal cough undergoes an upper endoscopy with
mhm,
esophageal biopsy. Light
mhm,
microscopy of the tissue
mhm,
specimen show elongation of the lamina propria papillae with several eosinophils and neutrophils scattered within the squamous epithelium. The
mhm.
patient takes metformin and enalapril for diabetes mellitus
Yeah,
and
okay.
hypertension, respectively.
Mhm,
He is started on pantoprazole, and after 2 weeks, his cough symptom resolved. Which of
okay.
the following was the most likely cause of this symptom?
Okay. The patient is having a nocturnal cough, an upper endoscopy with esophageal biopsy, light microscopy of tissue specimen show elongation of a lamina propria papilla with severe eosinophils, neutrophils scattered within the squamous epithelium. Like the patient is having esophagitis, right? So what's the cause of this inflammation? Okay, are you with me, guys?
Yes.
Yes,
Yeah,
doctor.
Yes,
yeah.
sir. Yeah.
The patient is having using metformin and enalapril for diabetes mellitus and hypertension, respectively. Then he started on the pantoprazole, azoles, pantoprazoles, omeprazole, rantroprazole, pantoprazole, all are PPIs. Okay, so this whenever we give a PPI, after 2 weeks, the symptom resolve. Which of the following is the most likely cause of the patient? Now you have got a little concept from this time. Now came to the option. Now, absence of esophageal peristaltic movement. Okay, what do you think? If there is absence of movement over here, if there is achalasia, no movement over here, or having a systemic sclerosis. Are you with me, guys?
Yes.
So, can these cause and any esophagitis, anything else? But I told you in systemic sclerosis, there will be fibrosis and sclerosis of the muscularis layer, not the lamina propria with eosinophils and neutrophils. Have you got the point?
Yes.
Now come another point. Now, what the allergen mediated esophageal disease. Allergen associated. It is due to. It is
Eosinophil.
Eosinophilic.
eosinophilic esophagitis. So basically, in eosinophilic esophagitis, it is allergen. So it means there is any hypersensitivity reaction going on, right?
Yes.
Yeah. So it means that it is due to anything that is causing the allergen that stimulates this esophageal that causes the esophageal esophagitis. Now, gastroesophageal junction incompetence. For example, the gastroesophageal junction is not closed properly. I've told you that if the gastric will be goes upward like this, and I told you that will irritate this mucosa, and that mucosa will lead to inflammation, and that inflammation will lead to esophagitis, and this esophagitis is called
Reflux.
reflux esophagitis. Have you got the point?
Yes.
There is no difference. Have you noticed the difference between reflex esophagitis and allergen esophagitis?
Yes.
And the patient, we have to exclude these two options. Whenever the patient take a pantoprazole, it is not antihistaminic, not anti-allergic. The patient resolve. So whenever I decrease the acid over here. So no acid came over here. The gold standard treatment for gastroesophageal reflux disease is PPI. Okay. Whenever we decrease the H hydrogen pion, so there will be no hydrogen going upward. So there will be no esophagitis as discussed in this stem. Okay, mucosal disruption after fungal infection. Is there any history of the fungal over here? If the fungal is present, the fungal infection is superimposed onto on following things. The patient will be having HIV. The patient will be immunocompromised, like having any kidney transplant, bone marrow transplant, anything else, and the patient will be having and on histology you will find a pseudohistophyte and pores like that. But the important thing in the stem that patient will be immunocompromised or HIV or hepatitis B virus like that. What about in viral infection like a herpes simplex and like that? But the patient also is also fungus and viral are superimposed infection. It superimposed on any immunocompromised infection. Okay, so the cytomegalo and not discussed in this patient, right? Pill induced esophageal mucosal damage. So basically, what are the pills? Can I
NSAID.
perfect like tetracycline and and anything and metformin and April does not causes any that does not cause esophagitis. But if you take in tetracycline, important thing, and any bisphosphonates are important in causing the esophagitis, right? So the patient is having a nocturnal cough and having a cephalic neutrophil in esophagus, and that are relieved with a pantoprazole like a PPI. So what's your diagnosis? It is due to the esophagitis is due to
Reflux.
reflux. Have you got the point? So there is a problem in this gastroesophageal junction incompetence. So that will lead to all the problem here. Have you got the point?
But what is there we found nocturnal cough. Cough is associated with esophagitis. How?
No, 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 no.
No, that's side effect of the drug he's taking.
Yeah, it's
He's
the
taking metformin and
Even the
enalapril.
cough. No, no, no,
S
even the cough.
inhibit cough,
It can
right?
affect cough because of the reflux, can cause like a gag
Yeah.
reflex, especially at night.
Ah,
This will cause
yeah.
cough. Many patients with GERD will come with cough.
Yeah, because there is like reflux of all of the food contents when you're sleeping, so it is more prominent at night.
perfect.
Okay.
Perfect. If you are sleeping like a prawn, these material when you sleep like a prawn, these material go into your trachea, right? In small amount. Whenever you find at night time you feel a cough. So this is basically extra esophageal symptom like nocturnal cough and like that. It is a basically extra esophageal manifestation. But the cough is due to the GERD, not due to any the drug is using. Okay?
Okay.
Okay, right. So I think you have got the answer or not?
Okay, but why are they saying there are eosinophils in this biopsy, the light microscopy?
Yeah. Is uniphils.
Like it says, light microscopy of the tissue specimen shows elongation of the laminar propria papilla with several eosinophils and neutrophils. So you said whenever there are eosinophils, it kind of says there's some allergy, right?
Yeah.
But in this case, how do we differentiate that?
Yeah. What about these neutrophils?
That's due to inflammation.
Yeah, that is acute inflammation. So in acute inflammation, you have the both of these. Now you have to differentiate on the basis is it at allergen or a reflux. This is your concept, right? This is your question, right?
Yeah. Yes. Yes, sir. Yeah.
Yeah.
Like when we have
Yeah.
both situations, like how do we decide which way to go?
On in this statement, in this step. So if
Yeah.
the patient is having allergen, whenever you give anti-allergen to this patient, the symptom will be resolved plus antibiotics.
But they don't mention, right, in the stem that they gave
Yeah,
anything.
yeah. So I'm coming to this concept. Whenever
Okay.
you having a reflex like a gastroesophageal reflex disease, the most important, the first line of drug for the GERD is PPI,
Yeah.
proton pump inhibitor, right? So whenever
Mm-hmm.
you give a proton pump inhibitor like a pantoprazole, the
Yeah.
after 2 weeks his cough symptom resolved. So mean that esophagitis is due to this reflux.
Mm. Yes, I got
I,
that part. Yeah.
I got the point.
Yes, yes, that point I got. I was just
Okay.
wondering that like how the eosinophil concept, like how do we eliminate that? Like
No, in normal inflammation and neutrophils and
they're
eosinophils,
both there.
both are there. But if it's
Oh,
typically mentioning the eosinophils, IgE
yeah.
eosinophil, then you have to go to the allergen, and then if the history of any allergen drug going on, then it will be a eosinophilic esophagitis. And the one
Yes.
important thing, and the one important thing, in eosinophilic esophagitis, that there
Yeah.
will be your you will having a intraepithelial eosinophils will be present, as not mentioned
Oh,
in this case. Okay?
okay, okay. All
Yeah.
right, I got it. Thank you,
Okay.
sir.
Uh, you're welcome. So now, if are you with me, guys? Have you clear the concept till now?
Yes, sir. Thank you.
Okay. Any volunteers want to clear the guy?
Which of the following is most likely site of this patient's gastrointestinal ulcer? A
Mhm.
55-year-old man comes to the office due to recurrent abdominal discomfort. He
Mhm.
also has bloating, a feeling of fullness, and indigestion. Vital signs are within normal limits, and
Mhm.
abdominal exam is unremarkable. Fecal
Mhm.
occult blood testing is positive. GI endoscopic procedures are performed and confirm the presence of an ulcer. The patient is told that the ulcer itself is very unlikely to be malignant based on its location. Which of the following is most likely site of this patient GI ulcer?
What do you think? I have told this question earlier.
Mm,
Whenever there is ulcer in the duodenum, it will
yeah.
be a
Uh,
rarely malignant. Otherwise, proven by a biopsy. Now,
yes,
any
that's due to.
ulcer except duodenum, all the ulcer except the duodenum, either it is esophagus, rectum, stomach, sigmoid colon, everything. The ulcer is most likely malignant, but you have to prove with biopsy. So you have got the answers. So
Yes.
the peptic ulcer disease are most likely not a benign one and can resolve. Okay, have you got the
Yes.
point? Perfect. So basically, the duodenum is that of the type. Perfect. So, all right, guys, come on, so that we can do the rest of the question. Okay, come on.
I can go.
Okay.
Um,
Yeah. Give a chance to anyone. Yeah, go ahead. A new volunteer. Hmm. Yes, go ahead, doctor.
Okay. Which of the following process is the most likely cause of this patient's heartburn? A 35-year-old woman comes to the clinic due to severe heartburn that is resistant to over-the-counter antacids.
Mm-hmm.
The patient has no known medical problems and takes no other medications. She
Mm-hmm.
occasionally has a glass of wine with dinner but does not use tobacco or illicit drugs. Physical examination shows scattered telangiectasias on the face, several ulcers at the tips of the fingers, and small calcium deposits in the soft tissues of the hands and elbows. Which
Mm-hmm.
of the following process is most likely cause of this patient's heartburn?
What do you think? Let's discuss it. Let's. Have you got the point? Having a severe burn, right? Heartburn, and that is resistant to over-counting antacid. Now, the physical examination show telangiectasia on face, several ulcer, tips of the finger, small calcium deposition on the palm. Any systemic disease is indicating, right?
Yeah, it's maybe kind of like systemic
Yes,
sclerosis.
some systemic
Yeah.
sclerosis, maybe.
Perfect.
Yeah.
So, systemic sclerosis. What will be the heartburn cause? I told you. This is there is
Fibrous,
fibrosis of
the muscle layer.
muscularis layer. So there will be muscularis layer. The muscularis cannot. There will be no. There will be a fixed esophagus, no contraction, no relaxation. So there will be a heartburn like that condition. Have you got the point?
Yes,
So
sir.
yeah. So there will be esophagus reflex over here. That esophagus will lead to the heartburn and everything. Have you got the point?
Yes, sir.
Okay. So what's your answer?
B.
Fibrous replacement of muscularis layer in lower esophagus, right?
Yes, sir.
So what is? Why not option C? Increased
That
gastric
might be
secre-
that
What
might be
is
in carcinoma.
perfect gastrinoma? I think you have cleared the pathology as well. Increase in resting lower esophageal sphincter tone.
Achalasia.
Perfect. Achalasia. I think you have mastered the pathology. Uncoordinated simultaneously contraction in the esophagus. We have discussed it. Uncoordinated, non-peristaltic, simultaneous muscle contraction in lower esophagus is
Balance.
DS.
diffuse
Uh,
esophageal spasm. Perfect. An abnormal location of the gastroesophageal junction. Simple. If this is located in the hair, is it hernia or not?
hiatal hernia.
Perfect. So I think you have cleared the concept of there is the difference between the achalasia, diffuse spasm, how we'll go to the hiatal hernia, paraesophageal hernia, gastrinoma, achalasia, diffuse spasm, and systemic sclerosis. Have you got the point? Have you cleared all the concepts?
Yes, doctor.
Yeah, perfect. Now you are now gaining and you are now having some brainstorming as well. That's a positive sign for me that you are also brainstorming.
Yes, sir.
No,
Thank you so much.
yeah, thank you. Welcome. Go ahead.
I can read this.
Yeah,
Which of the
okay.
following additional findings are most likely present in this patient? A
Mm-hmm.
43-year-old man come to the office with several month history of fatigue, rash, flushing, and abdominal cramps.
Mm-hmm.
His rash is worse with rubbing or scratching, and he has diffuse itching over after hot showers. The patient is frequently dizzy and light-headed after prolonged standing and had an episode of syncope while working in the hot sun.
Mm-hmm.
He used to be healthy and physically active, but has had reduced his normal activity. The
Mm-hmm.
patient doesn't use tobacco, alcohol, or illicit drugs. Vital signs are normal. Skin examination shows a maculopapular rash. Skin biopsy shows large clusters of mast cells that are positive for KIT, CD117. Which of the following additional findings are most likely present in this patient?
So what do you think the problem is going on? What do you think? Basically, yeah, yeah,
A
yeah.
histocytosis, something, histo,
Sorry,
it's called
sorry.
histocytosis, something like this. I forgot. There is something. It
Yeah,
was in
basically,
hematology.
yeah, yeah, yeah. You are
Mast
approaching.
cells.
So the mass are high. So it
Yeah.
means there are cluster of
Correct.
mice, right? It means there also allergy, mast cell allergy. Okay, so that allergy lead to cytokines. Cytokines, one of these is histamines.
Okay.
Okay, so
Okay.
I have told you, whenever this mast cell degranulates, it indicates allergy, and it degranulates into histamine.
Histamine.
Now,
Yeah.
ah, can anybody tell me the parietal cell?
Mm.
Let's discuss the diagram over here again. Can this histamine activate the parietal cell or not?
Yeah. It
It
can.
By
can activate.
by
Yes.
which by which process?
ECL.
Directly
Per-
ACLM.
yeah.
per- perfect.
That
H1 receptor.
So
Perfect.
it
This
provides that.
this histamine directly goes to this parietal cell to secrete HCl, right?
Right.
Also, let again revise. The G cell protrudes gastrin. This gastrin activate this. This also gastrin activate ACL. This ACL produce histamine, and
Amazing.
that histamine produce this. Also a vagus nerve. Vagus nerve produce stimulate G cell. G cell produce gastrin. Now having a high level of histamine will be produced by action of parietal cell. So there will be high acidic environment over here. Have you got the point? And the
yeah.
condition we have diagnosed this on the biopsy. We have this much knowledge. Okay. Now let's
Yes.
come to the disease. Now, okay, a patient having a rash, if it is a rash, so it means the disease is going toward a systemic site. Flushing, abdominal cramps, right? The rash is arose with the rubbing and scratching that has diffuse itching over the hot shower, right? The patient is dizzy, lightheadedness, prolonged syncope or hot sun, physical active, had reduced normal activity, right? So, which of the following additional findings are most likely in this patient condition? Okay, perfect. Bacteria colonization of stomach. Is there any history of H. pylori and SIDS, duodenal ulcer, relief with food?
No, sir.
No.
Perfect.
No.
Okay, any the history of the gastric atrophy,
No.
achlorhydria, megaloblastic
No.
anemia?
No, also.
Perfect. Is there any history of the gastric hypersecretion?
Oh,
Yes.
yeah.
Gastric
It's
hypersec.
happening because of this.
Yeah,
Yeah.
perfect. Is there any
Probably
history of the gastric hypomotility?
No.
Hypomotility? No.
No.
Perfect.
No.
No, any history of diabetes?
classified, no,
No.
Yeah. Yeah, doctor. You want to say something?
no, no.
Okay,
Thank you.
okay. Okay, welcome. There's any no least hypomotility, any history of diabetes mellitus, any
No.
history of hypothyroidism, constipation. In hypothyroidism, we will discuss in endocrine system, it causes high constipation due to low motility. Any history? No.
No.
Pancreatic endocrine tumor, men 1 and men
No.
2. Any history? Any relation?
No.
And pernicious anemia. Anyone?
No.
Perfect.
No.
So I think you have clear the concept of the all the thing. The pernicious anemia is caused by the achlorhydria and intrinsic factor. No intrinsic factor, megaloblastic anemia also cause gastritis and pernicious anemia. So I think you have got the concept over here from the mast cell, from the one sentence. You clear all
Yes.
this. I've got the point.
Yeah.
Perfect. So I
So,
think we have.
doctor, the dizziness is because I don't know if this is right. The histamine effect cause vasodilation. This will cause the patient to have like dizziness and lightheaded after prolonged standing.
Mm-hmm. Yeah, yeah. Basically, I'm not going into the depth of the disease because if you go,
Yeah, I
yeah,
know.
if you go to the depth of the disease, then you will mix the confuse in the stem. Basically, in this
Yes,
patient,
right.
yeah, let me discuss. It is having a systemic mastocytosis. The disease is that. You are right. If the patient is having a histamine release, there will be a vasodilation, flushing, and everything. You are right. You are right, but I'm not going into that detail because you will confuse. Just go from a very small point, you will easily got your answer. Don't diagnose the patient.
That can be
What
that
is
postural
reference?
hypotension, like they say, lightheadedness after prolonged standing. So this prolonged standing can also lead to postural hypotension and dizziness. That could be.
Sorry.
Hello?
Yeah, yeah.
What is CD117? Is it BCL?
Basically it is the present in the CCKMB receptor, right? It is helping in the increase this secretion of the mast cell.
Okay.
Okay, that is present, but
It's not related with the B cells like CD4
it's,
B
it
lymphocyte
is,
B
no, it is not.
lymphocytes.
No, B lymphocyte CD117 are not that related with the positive, but it is indicative of that patient is having it is present basically in the receptor tyrokinase. Basically, the protein help in the transcription of the gastrointestinal stromal tumor, right? It basically indicated in that, but don't go into the details of the CD9 and that. Basically, it is a protein that help in the stem cell receptor like that. And it help in the promotion of the stem cell factor substance that regulate the growth of the certain blood cells. Okay,
Thank you.
basically,
Okay.
okay, basically in it is cancer cell. If there are many cancers like some mast cell disorder, it is present in some. Basically, it is positive in gastrointestinal stromal tumors, like in this disease, systemic mastocytosis, certain leukemias, and central some kidney disease. These cells are positive. Okay.
Okay,
So,
thank you.
Did
sir,
yeah.
so one question, sir. So, if it was pernicious anemia, then how this case have changed?
Sorry.
Like in if it was like pernicious anemia,
Mhm.
like how these symptoms have changed? Like if it was that, like how would we eliminate it?
Basically, in pernicious anemia, you are having autoimmune gastritis, right? So that
Yes.
autoimmune gastritis will lead to the destruction of parietal cell and the chief cell. So whenever a parietal cell destroy, you will be having an intrinsic factor and a hydrocolloidia, like a and
Yeah.
megaloblastic anemia and achlorhydria. Have you got the point?
Yes, sir. Yeah.
Okay, okay.
Thank you.
You are welcome. So basically, the stem are too long, and you the many student confused that it's a big stem. Let's do it at the end. The big stem mean a short answer. Okay, just focus. Just first read the question. What the question is asking about. Okay, if it's asking about anatomy, physiology, or pathophysiology, then go directly. Just go to the stem in a 2 to 3 minutes and pick the small points. Okay, don't go into the diagnosis which disease is asking about and which is it is. No, just go into disease, just pick the point and then let you go to your options. Okay, that if you are not having no idea of anything, just do on the basis of exclusion. Have you got the point? Now,
Yes, sir.
okay, now go ahead with this question.
Can I read it?
Oh yeah.
Which of the following mechanism is most likely responsible for this patient's current symptom? A 26-year-old woman come to the office due to recurrent nausea and vomiting for the past several months. The patient
Mhm.
experiences nausea and epigastric discomfort after a meal and often feels full after eating only a small portion of food. Several
Okay.
occasions she has had a emesis containing particles of food that she ate several hours earlier. The
Mhm.
patient has 15-year history of type 1 diabetes mellitus, complicated by diabetic nephropathy. Her
Mhm.
medication include basal bolus insulin regime and lisinopril. She does
Mhm.
not use tobacco, alcohol, and illicit drugs. Vital signs are within normal limit. Abdomen is soft, non-tender with no organomegaly.
Mhm.
Bowel sounds are normal. Testing of stool for occult blood test is negative, and upper gastrointestinal endoscopy is unremarkable. Which of the following mechanism is most likely responsible for this patient's current symptom?
Okay. Okay.
Decrease act. Okay.
Yeah. What do you say?
No, no, sir. It's okay now.
Okay.
I'm
Okay.
done with
If
the stem. You can go.
okay, if you have any if you have any idea about the question, you can ask and you can go ahead. Okay. There is a no organomegaly. The abdomen is soft, no tender, and no organomegaly. We have excluded the GI, abdomen, everything. Bowel sound are also normal. The test for cold blood is also negative. There is no any history of lower esophageal, lower GI bleeding. Upper endoscopy also is unremarkable. No changes in upper GI or lower GI. So, which of the following mechanism is responsible of the current condition? So, what do you think the problem going on? I have also highlighted the problem.
This
Diabetic
type 1, type 1 diabetes is gastroparesis, like
dysfunction.
diabetic
Perfect.
nephropathy.
Perfect. I
Diabetic
think, yeah. I think
neuropathy.
you, yeah. You are now brainstorming. Now your brain are working. Almost you have done with 24 question, but your brain are also working. That's the positive impact that you are now thinking about the question. So what the question is asking about. Okay. Now, what do you think? What the problem? And what's your answer? Can
This
anyone?
C,
If all are agree with C or not?
because this is the neuropathy, so it's like
Now, if all are
this
agree, if all are agree,
eruption of the loads of figure center B or C,
yeah, why
abdomen.
B? Why B? Disruption of lower esophageal sphincter. What do you think of B? If there is lower
No,
esophageal,
no, no, because the endoscopy is normal. There is nothing.
then why?
The
Then why
yeah,
are you
yeah.
saying the lower esophageal sphincter is abs? Okay, are you with me?
How
Yes,
about
sir.
A,
We are.
sir?
Sorry.
Mm,
C
How
is the
about
answer.
A? C is also okay. A is also a little dubious.
because
Going
one is the
between A
enteric
and
neuron,
C.
other is the vagus motor neuron. So
I
there
mean, the
is
Yeah, that's
two.
cause is diabetic nephropathy, so it usually affects the gastric enteric neurons, no, sir?
Yeah, yeah, you are right. But the I have circled the most important point: the nucleus. The nucleus is present in the brainstem.
The brain.
yeah.
Okay, so any
Yes.
nephropathy,
So the vagus is affected more.
so vagus will be affected, but the peripheral part, not the nucleus part. The axonal part will be damaged, not
Okay.
the nucleus. You got the
Mm,
point. You have to
yeah.
read the question also carefully. Okay.
Yes.
Okay. Okay, sir.
Now you have got the answer or
Okay.
not?
Yeah. So it's C. Yeah. C.
Perfect. Perfect. Now, anyone?
An esophagogastroduodenoscopy is planned. This patient recent worsening of the symptom is most likely related to which of the following? A
Mhm.
30-year-old man with a year-long history of heartburn comes to the office due to worsening substernal burning. The
Mhm.
symptoms are particularly intense at night. Recently, the patient has also started noticing pain with swallowing food, although there is no sensation of food getting stuck in the throat.
Okay.
The patient the patient initially treated himself with over the counter calcium carbonate antacid, but the
Mhm.
treatment has become less effective recently. He
Mhm.
has no other chronic medical conditions. Recent HIV testing was negative. The patient takes no other medication. He drinks 2 or 3 beer each evening and smokes a pack of cigarettes daily. BMI 34, vital signs are within normal limit. Physical examination reveals no abnormality and esophagogastroduodenoscopy is planned. The patient's recent worsening of symptom is most likely related to which of the following?
What do you think? Is there any malignancy? Let's discuss. Any malignancy? Any
No.
No.
weight loss, anemia,
Normal.
anything?
Mm, no.
Nothing.
Okay.
No.
There is a no sensation of food stucking in his throat. So what do you think? Can we exclude the structure? If there
Picture,
is
yeah,
if
exclude.
Yeah.
there is structure present, so there the food will be stuck over here. So no any sensation of stuck in the food. Have you got the point?
Yes.
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 And what about this question? Recent HIV testing was negative.
Mm.
Can we exclude this?
Yes.
Yes.
Plus we can exclude the fungal infection as well.
Yeah.
Have you point? What is a columnar metaplasia? Also, is
Related to
Excluded.
malignancy.
it
So
is related to
excluded.
malignancy. Related to malignancy,
Yeah.
right?
Yes.
Excluded. Excluded. So what about what do you think? It's the
Rosette.
last option.
Yeah.
Rosette.
Now, basically, the man have a long history of heartburn that came to grossing substernal pain. Okay, the symptom particularly intense at night. I told you when you lie a prone, the acid goes into your esophagus and you feel a strong, severe substernal burning. Are you with me, guys? Also, there will be a nocturnal cough as well. Are you with me, guys?
Yes.
And what are the treatment? First line drug.
PPI.
PPI.
Yeah,
Perfect, perfect. PPI. So have you cleared the concept?
Yes.
Yes, sir.
Perfect. So basically, just on the basis of exclusion, we have did it. So Oh, right. So, how's your GIT going on? GIT is a big chunk, almost 300 plus MCQs. It is interesting or not?
So you
Yes,
made it
sir.
in.
It's
Very
very,
interested now, actually.
Uh, Yeah, I think
very true. Yeah, agree
uh,
with that. Yeah.
so. GI is very interesting, and I love GI. I love teaching GI, and GI, I love it. And we will discuss it. We will do a little gossip at the end whenever we complete at 31 MCQs. It's late as well. Okay, what is this? Can anyone tell me? Can anyone tell me this one? Like I
Air
really
in the gallbladder.
no no. This is
It's like
esophagus.
outpouching.
Like Baker, that assist,
Yeah,
Zinker,
yeah,
diverticulum.
yeah, yeah.
The gallbladder?
Mm.
No, 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 no. Oh my gosh. No, no. This is outpouching of
Is
the
diverticulum like
as
is
a
outpouching
here
from
to
the esophagus?
esophagus.
Hiatal
Yeah, here.
hernia?
Hernia, hiatal hernia,
Sorry.
like a
Is hiatal
hernia,
hernia?
hiatal
Let
hernia.
wait a minute. Wait, let's go to the
This is like
stem.
outpouching of the esophagus, like
You
zinc diverticulum or
you are
something.
right,
But
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 go.
why this esophagus is hyper-resonant? Why it's black? It is
Let
looking
There
like
is
a
let
air.
trachea, but this
let this
why
tell
this is
you.
hyper-resonant? Like this black translucency,
Have you
why in the
percussed it?
esophagus?
Have you percussed it?
No, I mean this translucent, like the picture usually this ear shows black, but why it's showing black in the esophagus? So
Can you?
I like this, we have this ear in the mind, but in esophagus, what the ear is doing?
I think you have
For
bored
me, if
from.
they didn't mention this esophagus, I would say this is ERCP. I was going to say on this. So it's good that they mention it's esophagus.
I think you all are bored and then you want to do a
Yeah,
little.
they did the this barium swallow, therefore it's looking black, I think.
Yeah, yeah. You can read the stem, then you can ask it is a gallbladder or it is a hyperresonant.
Because
No,
sir, you are just showing the picture to us and you asking the question. Because
no.
by
I was.
going to the stem, it takes you few seconds, I think maybe 1 minute to read all those details.
Okay, okay.
At
Go,
least
go,
for
go.
me.
Okay, go ahead. Go ahead. Go ahead with the stem.
So as shown in the image below, a 74-year-old man come to the office due to several months of choking spells, dysphagia,
Mhm.
and cough. He has also had a recurrent episode of pneumonia. His other
Mhm.
medical problems include hypertension and osteoarthritis. Blood pressure is 130 by 70. Patient has smelling breath. And his oropharyngeal and neck examination are normal. So cardiopulmonary examination is also normal. And
Mhm.
barium swallow studies performed and reveal an abnormality in the upper esophagus as shown in the image below. So
What you
this
are doing?
false smelling breath means so this outpouching from the esophagus. So like the food
Perfect.
material stuck over there, they give this smell
Perfect.
from the
Perfect.
breath.
Basically, I was. You have discussed. I
Yeah,
was just.
actually, I'm also really bad with this X-rays and CT scans, so I cannot do good prediction.
No, no.
I'm sorry.
Whenever you halitosis, this is your esophagus and outpouching over here, right? Have you got the point? Now, also there is contrast present in the anterior part as well. A little contrast over here, right? A little contrast over here. So it means there's also a tracheal respiration contrast. So, okay, this is your posterior, this is anterior, right? So this is your normal stomach. Okay, normal esophagus. Sorry, if it is esophagus, it should be like that. It is a normal, but there is an outpouching through this diverticulum, like this. Have you got the point? It's also indicating this
Yes,
is
yes.
esophagus. Then why are you going toward the gallbladder and anything else? Okay, so it is present in this esophagus and this bulging of this And
Actually, is a
the
pear.
black.
Actually, it is pear shaped, so everyone was
No, no,
thinking
no,
of
no, no.
that.
It is a basically esophagus. Okay, so the black color is due to your barium swallow, right? Whenever you barium swallow, you take an X-ray from it, so it look like this. Okay, I've got the point. Now, what's your diagnosis on the basis of the this stem?
Zinkers.
Zinc
Tankard
diverticulum,
diverticulum.
foul smelling breath, everything else. So, what is the pathophysiology of zinc diverticulum? What is the question asking about? Which of the following mechanisms are most likely cause of this symptom? So, what is the pathophysiology of this patient? Wait a minute, let's discuss in. Sorry, what do you think? Degenerative, degenerative changes in mesenteric plexus.
That is achalasia, right?
Perfect. Achalasia. Increase intraluminal pressure in stomach.
Malaria.
Perfect. Muller-Revesz syndrome. Perfect, doctor. Retention of cyst due to the duct obstruction. What do you think?
Is this thyroclustal cyst?
Retention
About
of.
pancreas. Pancreas.
No, 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 no. It is basically
Or
asking from a due to accumulation of trapped secretion falling up. It is basically a gland they are talking about. But the discourse is not that clear much. But scarring and traction of the esophagus.
The GERD, that one, no?
Basically, if the patient of scarring and traction, so basically it's
Roses?
present. Sorry.
granuloma,
Stricture?
Is it a
granuloma
rose?
formation. Scarring. Granuloma formation.
Yeah. Perfect. So scarring and traction and the granuloma formation, especially in the TB and fungal
Yeah.
infection, sarcoid also. Yeah, I got the point.
Yeah.
So what about this cricopharyngeal motor dysfunction?
Yeah, this is the answer.
So I think everyone have got the answer. The what is the problem? So do you know, guys, the problem over here? And is it a false diverticulum or a true diverticulum?
It is a false diverticulum.
Perfect, doctor. Perfect. It's a false diverticulum. In the false diverticulum, you know the concept. In the false diverticulum, you will having the protrusion of mucosa and submucosa, no protrusion of muscularis layer, right? Yeah. So can you give the example of one true diverticulum?
Yeah,
Mecals.
mucus.
Mecal.
Metal diverticle.
Perfect. I know. I know. Now you can know the answer of the question. Okay. A creek of ranges, right? So basically 27, 28, 29. Yeah. Okay. Anyone?
Okay. Which of the following is most likely cause of this patient's symptoms? If 45-year-old woman comes to the office due to colicky, abdominal pain, diarrhea, and nausea 15 to 20 minutes after meal. These episodes of accompanied by light headaches and diaphoresis. She
Mm-hmm.
feels normal between the episode and episode and at night. Um, the patient uh, underwent wrong and
Mm-hmm.
why gastric bypass surgery 4 weeks ago for obesity. Is the dumpling syndrome something dumpling? She is otherwise healthy, and all
Mm-hmm.
her only medication is daily multivitamin. On
Okay.
physical examination, the patient has a well-healed midline abdominal scar.
Mm-hmm.
Mid-epigastric tenderness on palpation is present.
Mm-hmm.
The remainder of the examination is normal, and each of the following most likely cause of this patient symptoms.
What do you?
So, hold on. I am checking from the bottom. Spasm of the pyloric sphincter, rapid transition of the hyperosmolar food in the
Mhm.
small bowel, post-surgical scarring of the stenosis
So
site, increased bundle, contractile vagal, laryngeal,
simple.
bacterial. Uh, is this the D or maybe or D or C?
Okay. Let's discuss.
Like
What's the
dumping syndrome. This one, no dumpling.
Yeah, it's a dumping syndrome. Perfect. Basically, if you know the row XY gastric bypass surgery in the bariatric surgery, you will know the answer. Basically, what happened in the ROX and Y bariatric surgery? It's basically used in the bariatric surgery. For example, this is your esophagus, stomach, duodenum, right? Then your ileum, right? So what's happened? Basically, the stomach is bypassed in this surgery. How? Like that. Stomach is present over here, right? This is esophagus. Basically, these stomach they attach here and directly they go over here. So we have bypassed the surgery, bypass the stomach over here. Okay. So what will it do if the food, the undigested, the food? So what is the function of this stomach? Storage. Okay, crushing and, and proper digestion, right? If you eat food, that directly goes into the ileum jejunal anastomosis. Basically, it is a jejunal, right? It is anastomosis jejunal. Okay. Now, the undigested food, uncrushed food have directly go into the jejunum. Have you got the point? So, this creates a hyperosmolar state in the lumen. Have you got the point? So from the blood vessel and from surrounding it absorb the water and everything fluid over here. So in the blood vessel causes hypotension. So it activates sympathetic system. Have you got the point? This this is the one. Number two. This high content food, undigested food came over here that cause abdominal pain plus diarrhea. Okay, and this hypertension volume causes dizziness and diaphoresis. This sympathetic nerve will cause a diaphoresis like sweating, and lightheadedness will cause hypotension. Have you got the point till now? Have you got
Yes,
the
sir.
point?
Yes, doctor.
Yes, sir. Can you explain this when the food go directly in the jejunum?
Yeah, this food, what is the function of stomach? Stomach store, stomach crush to help to ensure the proper digestion of food, then relieve through this pylorus a small quantity of food over here for absorption. Right? Whenever we bypass the stomach has been bypassed. So the large food particle will directly goes to the jejunum and ileum. So that will cause an state that will be hyperosmolar state in jejunum. That hyperosmolar state will attract water into the lumen, attract fluid into the lumen. That will cause the hypotension in the blood vessel. So whenever there is hypotension, so the systemic circulation will cause the sympathetic activation. Okay? So all the system will be alert. The patient is having going a hypertension shock. So sympathetic activation will be activated. There is a heavy fluid in this, so all the fluid will be absorbed. The patient will be having abdominal cramps and diarrhea as well. Okay,
Okay, thank you.
and Their sympathetic causes will be diaphoresis and everything else. Okay. Now let's come to the MCQs options. Bacterial growth, our growth in a surgical created blind lobe. If there is a bacteria, fever present or not? Is there any fever or not?
No.
No fever.
Perfect. Perfect. So we have excluded this. Increased gastric fundal contractility from the vagal nerve injury. What do you think? If you damage the vagus nerve, what will happen? So there will be, if we damage the vagus nerve.
Gonna be
So
No
dysphagia,
contractility.
unable
No
to
contract.
swallow,
sorry.
unable to swallow, and with no contraction is gonna be.
No
Yeah.
contractility.
Perfect. 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 And what about the post-surgical scarring and stenosis of gastrojejunal site?
The food will be stuck in that case, right?
Yeah, perfect. So
Foul smell.
yeah, so the food will be stuck over here, there will be a vomiting, and there will be bilious vomiting, right?
Yeah.
Any history? No.
No.
A rapid transition of hyperosmolar food into small bowel. Is it making sense or not?
That
Yes,
makes sense. That is the
that
answer.
makes sense.
Yeah. Spasm of the pyloric spasm. It will be present over pylorus stenosis over here, but it will cause a vomiting, non-bilious
Vomiting.
vomiting, and also it
Preference.
will, yeah, it will present, but no gastrophoresis and diarrhea. Okay, you got the point.
Yeah. So when you say bilious vomiting, it means the vomit has like a mixture of the bile also, right?
Yeah,
Yeah.
I mean that cause if we're having a bilious, so the cause is below this ampoule of water. Okay, if non-bilious, the cause is above the ampoule of water. The cause is over here. If it is bilious cause, the cause is below the bilious point.
Below,
Okay.
I see. Okay, okay. Thank you.
Welcome. So have you got the point? Have you got make any sense?
Yes, sir.
Perfect.
Yes,
Thank
it
you.
does.
Now, can anyone?
I can
Okay.
do it.
No.
Yeah, yeah. You can take. Both can read.
Okay.
Okay, that.
The process directly responsible for causing this patient's mucosal tear will most likely resolve which of the following acid-base disturbance.
Okay.
38, a 34 years old man with upper gastrointestinal bleeding is brought to the local emergency department by ambulance.
Mm.
He was found in front of the grocery store after customer called emergency medical services. The patient is unable to provide any information, but his medical report shows history of the alcohol use disorder. After
Mm-hmm.
ongoing evaluation and appropriate resuscitation, his condition stabilizes. Gastric lavage fluid initially contained blood cleared quickly. Upper endoscopy showed linear mucosal tear at the gastroesophageal junction.
Mm.
The process directly responsible for this causing this patient's mucosal tear will most likely cause in which of the following acid-base disturbance? Uh, it's gonna be
Yeah.
probably. Hold on,
So, so
can I
um,
start the eliminating question or not? So respiratory alkalosis. I don't think so.
so can you diagnose
And
the patient
um, okay, so
having esophageal tear, right?
esophageal tears.
Either Molluri-West syndrome or Borhave syndrome.
I think it's Borhen's maybe.
Yeah.
No,
How? No. How it is Borhave or how it is Molluri-West? Can anyone? I will explain it earlier.
Sir,
Now,
the
it
patient came in emergency department by ambulance, so it most probably were have because it's a serious and more Serious than
Transfer.
the
Perfect.
malarious one.
Perfect. Perfect. The malarious patient will be a normal patient. He can give a history. He can give everything. But the Borreliose syndrome, will be patient will be having an shock, fever, and a shock. Have you got the point?
Yes, sir.
Yes, sir.
Yeah. Now the patient is having a vomiting, right? So in vomiting, the acid excreted from the body, and there is a base present in the body. So what do you think? It is alkalosis, right?
Yeah, alkalosis.
What type of alkalosis? Respiratory.
Metabolic.
Perfect. Metabolic alkalosis. So I think we have got the answer. Or not.
Yes, sir, we got it.
You got it or not?
Got
Yes,
it.
We,
sir.
we, we will discuss the high metabolic, high anion gap and normal anion gap. We will discuss it's not that
Okay.
high for the step one, but to remember the cause, we will discuss it in further detail in the next classes. So just remember, if a patient having a diarrhea, severe diarrhea, so what do you think? It will be in diarrhea base loss. So it will be base loss and acid remain in body. So it is
Metabolic.
Metabolic acidosis.
Acidosis.
metabolic acidosis.
Metabolic acidosis.
Perfect. Now, if the vomiting is deep,
Due to hydrogen loss, right?
if,
Loss of protons.
yeah, if the vomit, now if the vomit is from stomach over here, that it will be metabolic alkalosis, right?
Yes, yes.
If the vomit is from the ileum or jejunum, so what would it be? Can anyone?
I
Carbohydrates.
Metabolic?
Alkalosis.
Meta-
Acidosis.
metabolic is a bicarbonate present over here, right? So we have removed all the acid first, then after that bicarbonate removes. So what do you think? If
Metabolic acidosis.
perfect, the metabolic acidosis. So that don't confuse yourself that within this it's a little bit difficult. But for now, just remember the causes of metabolic acidosis and metabolic alkalosis. We will discuss the normal line gap and high anion gap in the next question. Okay? Or in the further question now. All right?
Yes, sir.
Okay, thank
yes.
you. Now, now. Okay, guys.
The patient will require lifelong administration of which of the following substances? A
Mhm.
53-year-old man comes to office for the routine follow-up after total gastrectomy. The patient was recently diagnosed with a gastric malignancy after several months of weight loss, fatigue, and anorexia. He underwent an uncomplicated total gastrectomy and has no post-operative complication. Which of the following will require long-term administration of which of the following substances?
Which of the following is what do you think?
Gastric enzymes, total gastrectomy.
Why gastric enzyme?
No.
Water soluble vitamins. Is this A?
Sorry?
Water soluble vitamins. Water
Perfect.
soluble
E.
vitamins.
Water soluble
Perfect.
vitamin. A.
AD.
What do you think? A, B, C, D,
E. Vitamin
I think
B12.
A.
Oh,
B.
B and C. B.
B, or C?
B.
And
B.
anyone? What
I
about
think
What
E.
about E? Water
E.
soluble
I think
Water
vitamin.
soluble
E.
vitamin.
what about
B12
T?
supplementation.
What about T?
Yeah, E answer.
Yeah, it's E, the answer.
B, I
You?
guess.
And what
Because the
about
Yeah,
vitamin I think it's vitamin B12 is like a cofactor, so it's not gonna be there because of the gastrectomy, right?
Yeah,
And
yeah.
water
Basic.
salt vitamin.
Yeah. Mm,
So
mm, mm, mm.
B or E? Confused between B and E.
B or A.
Yeah.
I think
Mm.
if we
No
don't know
intrinsic
it,
factor. That's why no
So
vitamin
why
B12.
not? So can you have a thinking of the if what is the cause of the HCl? HCl activate the proteases, right?
Yes, sir.
So are these proteases present in intestine?
No.
Yeah,
Yes,
30%.
No.
yes, they are present.
30%.
They are present.
Yeah.
And are they present in pancreas?
Yes,
Yes.
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 So I think we have excluded this chloride, right? Its work
Okay.
will be done by intestine and pancreas. So what about the gastric enzyme? So gastric enzyme are also the proteases, right?
Yes.
All function is to activate the parietal cell, and gastrin activate the parietal cell, the D cell activate the negative inhibition, right? And all the what the gastrin do, they activate the parietal cell activate the pepsinogen and pepsin. So what does peptin do? It also have kind of proteases, like, okay. So it work will be done in intestinal and pancreatic fluid. Okay. So we have excluded the gastric enzyme, HCl, and hydrolyzed dietary protein. We do not need to any hydrolyzed food because it is hydrolyzed by the intestine and pancreatitis. What about the medium size, medium chain triglyceride? I think it is not the.
Pancreas is working fine, not needed. So
Yeah.
it's E.
So
E.
yeah. So vitamin B12
12
deficiency. You
divisions.
have to take it as a symptom patient from outside. Have you got the point?
Yeah.
yes, sir. Yes, sir.
Perfect, perfect. So it is basically the water soluble vitamin B12 you have to absorb from this. Okay, 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 right. Can anyone?
Okay. Do you want me to read again?
Yeah.
Okay. Esophageal monometry is performed after single swallow of 5 ml of the water. The
Mm-hmm.
tracing appears shown in the image below,
Mm-hmm.
right?
Mm-hmm.
Okay. So 43 years old. Oh, which of the following? Hold on. I'm sorry, I don't see the
Wait a
question.
minute. Okay, okay, okay.
Okay, which of the following is most likely diagnosis on this patient?
Okay.
Okay. Uh, okay, hold on. 43 years old man evaluated for retrosternal discomfort and dysphagia for the past several months. He smokes pack of cigarettes daily and drinks alcohol on weekends. His BMI is 32.8 kilogram and physical examination is unremarkable. Esophageal manometry is performed after single swallow of the 5 ml of the water tracing, which is
Mm-hmm.
uh, tracing up here. Okay, so we have to find out this one. I am not okay. I don't know this one yet, but it looks okay. I don't know. It can be achalasia or um,
Mm-hmm. Mm-hmm. You're going to
maybe.
the right side. You're going to the right side. But what do you think?
Decrease lower esophageal sphincter.
Oh, look at the normal here, though. It's like normal is all up error.
Normal is
Esophagus.
here and
Okay.
patient is here. Okay. This is normal. This is same. This is also same. Little bit problem, not that much. A little problem. Yeah. So in lower esophagus, upper esophagus sphincter, lower and lower esophageal sphincter, you can see the difference. Wait a
So
minute.
problem is in the lower esophageal
Yeah,
Lower
sphincter.
esophageal.
you can see
Yeah.
this diagram and you can see this diagram. So this is 80. It is toward the 70 and it is present in 60. So in patient, the lower esophageal sphincter is increased. The lower esophageal tone is increased.
Yeah.
So what do you think?
Scleroderma.
Barrett's esophagus.
Sorry? I told you.
Barrett's es-
Achalasia.
Yeah. Yeah. So what about the scleroderma? It will be over here.
Tone
Decrease.
So there
decreases.
will, yeah, so the scleroderma, there will be a decrease and spectrum. And what about the esophageal spasm? Diffuse is what will be
So,
happen?
The upper
so can we go over
esophagus,
like the
Sorry,
Oh, no.
upper esophagus,
basically
It will be
With the
decreased
spurs.
diffusely.
it will
Overall
be
esophagus will be decreased in
perfect,
DES.
perfect, perfect. It will be having all the esophagus will be increased like that. If it is a present, if pharynx will be normal, okay, no, upper esophagus will also be normal in all the cases. In scleroderma, achilles, and diffuse esophageal spasm, there will be no problem here, but the problem start over here, right? In achalasia, for example, the patient is achalasia, and we discuss it scleroderma, systemic sclerosis, or a diffuse esophageal spasm, right? So, in achalasia, all the thing will be almost normal, but the problem will be over here. There will be lower esophageal sphincter tone will be high. Okay? In systemic sclerosis, all will be almost normal, but the lower esophageal tone will be low. This is normal, right? So lower esophageal tone will be a lower than this one. Okay?
oh,
In diffuse esophageal spasm, the problem will start over here. There will be spasticity over here. There will be spasticity over here. There will be diffuse spasm is over here. Also, there will be a decreased downward temp over here. Okay, so this is the your diffuse esophagus. Whole diffuse esophagus will be have a spasm. Okay, have you got the point?
Yes, yes.
Esophageal
yes, yes.
achalasia high is lower esophageal tone. Systemic sclerosis decrease and diffuse esophageal spasm diffusely increased tone in esophagus. So which of the following is most likely diagnosis in this patient? So what do you think?
Achalasia.
Alicia.
Everyone
It's
is
a yeah.
yeah, okay. Everyone is clear.
Yeah. Yes.
So yes, sir. So can you just explain once more, like how that could be different from the from option B?
Let me discuss it in this diagram.
Yes.
Yeah, okay. So in all the cases, the pharynx and upper esophagus will be normal. Okay, we got the point.
Okay.
Yeah.
Yes.
In scleroderma achalasia, the problem came almost over here.
Mm.
Also, the lower part is also in the downtown, middle is also in the downtown, and upper is almost same.
Yeah.
Okay.
Yeah.
Secondly, the problem, do you have noticed the lower esophageal? This is normal one, right? And this
Yes.
is low one.
Yeah.
And in achalasia, the both are the distal esophagus, present in
Yeah.
distal esophagus. From here, we know the one point, the both are present in distal esophagus. Whenever there's the, if you know the distal esophagus sphincter is low, diagnosis
Yeah.
will be scleroderma. If high, achalasia. If all the esophagus having a, okay, is a diffuse
Mm.
esophagus. Now, achalasia going on onward, onward. This increase over here. Okay,
Okay.
so
So
increased tone over here, decreased tone
yeah.
over here, and in diffuse spasm, whole esophagus is having a high tone.
I don't. I see.
Okay, diffuse. All these figures is have you
Sir,
got it?
so in scleroderma, there will be decrease lower esophageal sphincter tone.
Yes.
And in achalasia, there is increased tone.
Yeah, yeah.
Okay, thank you. Just clearing. Thank you, sir.
Okay, okay, okay.
So symptom wise, it's always going to be the same thing. So we will differentiate it based on this
No,
graph that they give.
no, 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 no. If there is a low tone, right,
Oh, tone. They
there
will
will
tell
be
that.
reflux, burning
Oh,
sensation, like a GERD, right?
all right. Okay.
Is there any GERD in high tone?
There will be
No.
obstruction of food.
There will be obstruction. There would be the bird beak appearance in echology, right? And there will be
Mm.
obstruction over here, a vomiting as well. And what about diffuse spasm? You have solved 2 or 3 MCQs on diffuse spasm.
Yeah.
Okay, so it's not important that that in the step 1 exam you will only give a esophageal manometry to diagnose all that is. No, on the basis of history you can do as well.
I see.
Okay, if there
Okay.
if there is a problem in any systemic disease going on and there is a low esophagus sphincter having a GERD, then go with systemic sclerosis. If everything is
Sclerosis.
fine and everything is fine and only there is having a strong manometry in the lower esophagus symptom, but what's your immunological finding? There's a no of achalasia, and achalasia is followed by no mentoric plexus and everything present. It. Have you got the point?
Yes. Yeah.
To know all the basic as well. You know the cause of the achalasia, you know the cause of esophagism, you know the cause of everything. I think you have clear. You should brainstorm in everything. Okay,
Mm. Okay, so thank you.
let's discuss the last question, and I think, yeah,
I
everyone.
can do it, sir.
Okay, okay.
Which of the following is the most likely cause of the patient's symptoms?
Mm-hmm.
A 28-year-old woman at 32 weeks gestation is
Yeah.
seen in the office for a routine prenatal visit. The
Mm-hmm.
patient has had burning, squeezing pain in the middle of her chest that lasts for minutes to hours at a time and usually occurs after meals. The
Okay.
pain the pain is occasionally accompanied by small amounts of sour tasting material in the back of her throat.
Mm-hmm.
The patient does not have any abdominal pain, emesis, or visible blood in the stool. Her
Okay.
pregnancy has been complicated by gestational diabetes mellitus, which has been well controlled with nutritional therapy and exercise. She does not use alcohol, tobacco, or illicit drugs.
Okay.
Vital signs are normal.
Mm-hmm.
Fundal height is 32 centimeters and fetal heart tones are normal. Which of the following is the most likely cause of the patient's symptoms?
What do you think?
Delayed gastric emptying.
This
Sorry.
32, this is 32-week pregnancy. Because of the pregnancy, decreased lower esophagus sphincter tone most probably.
Perfect. One of students
Good.
said, no, one of the students said delayed gastric emptying. Why delayed gastric emptying? The diabetes is controlled, not uncontrolled. So
Okay.
if not mentioning this control, then you can say it is a delayed gastric emptying. If it is controlled, so you have to exclude this. Have you got the point, doctor?
Yes, yes,
Okay,
you're
okay.
right.
Diffuse spasm of esophageal smooth muscle.
No.
Perfect. Helicobacter pylori.
No.
No,
Increased gastric acid production, gastronoma, anything
Yes.
else?
No.
So what do you think?
A.
Have you got the answer or not?
Yes, sir.
answer is A.
Thank you very much. So it's- the class is too much long. I think we have taken a 4 hours. So how was it today, class?
It was
It
awesome.
was
Thank you.
excellent, sir.
Oh, it was
Thank you
long
so
and
much.
awesome. Thank
The
you so much.
best.
We enjoyed the
Thank
class,
you very so
even though
much.
it was long.
Sir,
And
can we
kindly,
start little? Is there any possibility? Can we start this class little earlier? So it's
yeah,
getting too
basically,
hard for us. It's
okay,
too
okay.
long,
I
and is
Yep.
there any way to start little early?
Basically, I am also having a very busy schedule, and I'm also having that 4 to 5 hours free time, and that time I sacrifice for you guys. You know. So after that, I'm having a class with another students, and very having a very busy schedule. So we will just adjust it in the further in next ongoing days. We can do it a little bit earlier, and that we can do it, but we will discuss it with the team and then our early schedule as well. Then we will discuss it. Okay.
Sir,
Okay.
sir, if we cannot start the class earlier, can we please do these long classes on the weekend? Because in the weekdays it's very difficult to attend the class.
Okay, sorry, doctor.
Hello.
Can we? Okay, Doctor Peter, can you please mute your mic?
Any station where you go, you sit down. You need two questions there. You
Please.
answer after the 2 minutes. You come back.
Hello.
Dr. Peter, your
Yeah, Doctor
Dr. Peter.
Peter, mic is on and causing a problem over here. Yeah, Doctor. Yeah, so
Yeah, sir, I was saying like if we cannot start the class earlier, so is it possible that these long 4 hour or 3 hour long classes can we please do these classes on the weekends? Because in the weekdays it's very difficult to attend this long class.
so our main problem is that our daily question are 20 to 25, right? So
Yes.
as you know that gastroenterology a big chunk, so we have take a 25 to 30 question daily, right? So if we do a 15 to 10 to 15 question daily, that it will be difficult for us to complete this in 90 days. And also there is a catch up day in between the weeks and our busy schedule. We can also give 1 to 2 holidays. So it will take more than 100 days or 120 days to complete the hour. By our policy and our timetable, we have to complete this in within 100 days. And you have to take, in for the step one, you have to take your time to study and to pass the exam in this in the December or January, right? So you have to sacrifice yourself. You have to give more time to your study, and you have to gain more think. Is it making sense?
Yes,
Yes,
sir.
sir. I know, but
Everyday, yeah, the
Yeah,
everyday
we have
class
to give
helps
all the
like it
time.
keep us on track. Like it helps
Yeah.
like every day we having the class and every day we're going to discuss the topic and question. It helps to cover. But this time management, if the Dr. Danesh class is shift 1 hour earlier, so we can start like 1 hour earlier, so it will be more helpful because too late we cannot concentrate and we have families and children and a lot of other stuff going there. So
Okay.
it's too hard to adjust.
so yeah, sir,
Yes.
I like your point is right. Your point is valid. But the problem is that there are so many mothers in the group. Like I am a mother, so I have responsibilities of my kid too. So I really want to attend the whole class, but with the other things going on, if class time is decided that this is the class time, so we will be able to manage the time according to that thing.
Our
Like if
fixed
we
time.
don't know how
Okay.
long the class is going to be, then it gets very difficult to take the class and
Mhm.
doing other things, and we cannot concentrate that.
Okay, 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 okay.
But
We will discuss it with our team. We will have a meetup this weekend, and we will let you know. Our starting time will be 2 p.m. Eastern Time Zone. Okay. Then our ending time will be. Then if we go rush to the MCQs, then you cannot understand the points. If
No,
I
no,
hold
sir,
it
we
up.
don't want a rush. We
yeah, no,
want
no,
like
no. We
one
don't want to
hour
rush.
earlier.
We like the
We
way you're
don't want to
doing.
rush. Like, if is there any way like from two if go to one, like we start 1 p.m. at least like 1:30 before we starting at 1:30. That was also little better. So
Okay,
when the time is two, but it's almost if you're going to start, it is 2:15 and 2:20. Sometime like the students come and they adjust and the things go in the flow. It
okay,
still take like say 10-15 more minutes. So sir, we
okay.
want like a total benefit from this course and from your knowledge.
Mhm.
So please adjust the time. Thank you.
Okay, okay, okay. We will discuss it with the team and we will let you know. Okay. Okay,
Thank you
doctor.
so
Thank
much.
you, sir, for everything.
Yeah,
Thank
thank
you
you
for
very
your
much. The
help.
class
Also,
was
also
yeah, the
give us
class
Thank
was
you,
The
very
sir.
class
good.
was great.
also give us feedback in the group as well. So
Excuse me, doctor.
yeah, doctor.
Yeah, this is my first time I join your. I really like it. So I'm an old graduate here in the United
Okay,
States. Right now I'm doing echocardiography. So I
okay.
like it. So I request if it is exact time, so that everybody can join it. And is it every day like the 100 days marathon?
No, it's a 90-day UWorld discussion program. What's your good name, doctor?
My name is Mohammed Zahiri.
Mohammed Zaid. Okay, it's a every day program and it's a 90-day UWorld discussion program. and it's a different program for the marathon program.
Okay. So
Okay.
marathon is different.
Yeah, yeah.
Oh, I received the message. I thought that this it is just for you world.
It's just for you, all right.
So we have to get enrolled in this and also in marathon separately.
Yeah, it's a separate program. Both are separate program. You have to separate enroll in this and separate in marathon.
So then how should we first finish the marathon, then enroll in the U world or in the same time?
Both are on the same time. You have to enrollment in the both the time. So for example, if we are having a marathon cardiovascular system going on in marathon, then one time you have to done a marathon of the cardiovascular system, 10 to 15 question of the marathon of the CVS. Then with us you can start the gastroenterology. Then you can cover both the system side by side.
So what is the difference between marathon and U world then? I
Basically,
haven't I
okay.
haven't joined the marathon
Yeah,
because this was
basic.
just
Okay. Okay. Basically, in marathon, we discuss the whole topic. For example, we discuss the cardiac anatomy and cardiac neurology. For example, no discussion of the UWorld questions, right?
okay.
Just whole cardiac neurology. First aid, Dr. Danesh Kumar will teach all the high yield point. You have to practice the
Okay.
MCQs by yourself.
Thank you. I got it. So then I have to first, in my opinion, join the marathon. After finish that, so I have
Hmm.
to give it 6 months. Then join with you the U word. Thank you. I got it.
Okay. Thank you very
Okay.
much,
Yeah.
doctor. Thank you.
Bye.
Thank you. Thank you. Thank you. Bye bye. Also, give us a feedback on the group so that I feel um,
Absolutely.
I feel perfect.
So, towards the end of September, what topics will be covering after GI?
Yeah, doctor. We will cover the endocrine system.
Endocrine, right? And after endocrine, will you be doing CVS
Yeah,
with
yeah,
us?
this. Yeah, CVS and CVS neurology, everything.
You will be doing with us, right?
Yeah, yeah, yeah.
CVS and neuro also.
Neurology.
Neurology, I see.
Yes.
So after this
MSK.
endocrine, and after endocrine, what are you going to do, sir?
MSK.
MSK. Okay, okay,
MSK
great.
Dharma, then like that.
And derma. Okay, okay. So you're
Okay.
doing the small systems first, and then you're going to keep the very big topics to the
Yeah.
end. Is it?
So like a
I.
renal and pulmo, then gastro, a large one, then a two small one, then a large one, then two small one, then a large.
Oh, okay, okay, okay. That makes sense. Okay, great.
Okay, doctor.
Okay, Director, thank you so much. I
Thank you.
appreciate you taking the time, and it's really great that you're really dedicated to teaching. Thank you so
Okay,
much.
okay. Okay, thank you very much, doctor. Have a good day. Bye bye.
You too. Bye bye.
Thank you. Feedback in the
Bye
group
bye.
as well.
Yes, indeed. No problem. Thank you.